Good afternoon, everyone. We're just going to give it a moment before we start the session to give people a time to join the webinar. Great. Welcome, everyone. As you're joining, please feel free to introduce yourself in the chat, and we'll just get started in just a second. Thanks so much for joining. All right. Thank you all so much for joining the Hepatitis B Foundation's Be Informed Virtual Patient Conference, which is hosted by the Foundation and supported by GSK. My name is Catherine Freeland, and I'm the Associate Director of Public Health Research at the Foundation, and really appreciate all of you tuning in today. Today, we're looking forward to some really enlightening presentations that are focused on a variety of really important topics related to hepatitis B. These focus on understanding the science of hepatitis B, looking at what a functional cure is and how we get there, the current research in the pipeline, and hearing directly from those with lived experience, which we're really excited about. We have an esteemed panel of speakers, all really experts in the field, and we're thrilled to have you all join us today. Next slide, please. I'd like to start by doing some brief housekeeping. If you're able, feel free to introduce yourself in the chat, as I see many of you are. I'd also like to let you know that this is a Zoom webinar, so you can know exactly how to participate throughout the day. All audience members will be muted, but we encourage you to use the chat feature and let us know who you are and where you're joining from. If you have any technical challenges, please let us know by using the chat box, and we'll do our best to address it as soon as possible. At any time during this discussion throughout the day, you can use the Q&A box to enter any questions. These questions will be addressed by our panelists at the conclusion of the discussion in each section. This session is also being recorded, and the recording will be shared with anyone who registered and the attendees following the webinar. Next slide, please. Just to let you know, today's session is being translated into 3 languages: Chinese, French, and Spanish. To use the translation feature in your Zoom window, scroll to the bottom and you'll see, similar to the figure on the slide here, an interpretation section. From there, you select which language you would like it interpreted in. The interpretations will also be recorded and shared on YouTube as well, and accessible to anybody who needs that. Next slide, please. So we'd like to start out by launching a quick poll to learn where you're calling in from today. If you could please help us and share where you're calling in from. And then also there's another question asking, how do you identify yourself? So we'll give you a few minutes to fill that out. Amazing. I'm seeing in the chat we have folks from Ghana, Canada, Liberia, Pennsylvania, New York, Albania, South Dakota, Canada, Uganda, another individual from Ghana, Nigeria, California. Lots of representation across the board. All right, so given that we have about 70% of participation in the poll, I'm going to go ahead and share the results with you all so you can see how people responded as well. So hopefully you're able to see, we'll share the country representation as well, but I also see someone from Ukraine and South Africa. We're really appreciative of you joining. And it looks like folks are identifying as individuals living with hepatitis B, community advocates, and healthcare providers. Thanks everybody for joining. Next slide, please. At this time, I'd like to just share a bit about the agenda and what we're covering today. We'll start with a welcome from the president of the Hepatitis B Foundation. We'll then discuss a hepatitis B and Delta overview with Dr. Sue Wong, who's the medical director for the Chinese medical program at Cooperman-Barnabas Medical Center, past president of the World Hepatitis and board member and advisor to the Hepatitis B Foundation. That will be followed by what is a functional cure and how we get there discussion with Dr. John Tavis, who's a professor of medical virology at St. Louis University. This will be followed by a presentation from Dr. Tim Block, who will share updates on hepatitis B and Delta treatment and the current pipeline. This will be followed by an esteemed panel of storytellers who will share their lived experiences and challenges living with hepatitis B, and will share their stories that they made in partnership with by the foundation. And then we'll have closing remarks by Dr. Cohen as well. So I'd like to go to the next slide and introduce to you all Dr. Sherry Cohen. Dr. Cohen is the president of the Hepatitis B Foundation, which leads national and international efforts to eliminate hepatitis B through developing partnerships, capacity, and strategies to improve hepatitis B and Delta screening, vaccination, and linkage to care. Welcome, Dr. Cohen.
Thank you so much, Catherine. Much appreciated. On behalf of the Hepatitis B Foundation, it is my pleasure to welcome you all today to the Be Informed Patient Conference. As Catherine said, the Hepatitis B Foundation is a global nonprofit organization dedicated to improving the lives of all of those living with or impacted by hepatitis B, hepatitis Delta, or liver cancer. We do this through public health research and programs, outreach and education, policy and advocacy, and grassroots community engagement. We work locally, nationally, and globally to prioritize hepatitis B, Delta, and liver cancer, to make sure that research continues for better treatments and a cure, and to increase access to screening, vaccination, care, and treatment. We hosted our first ever Be Informed Patient Conference in June of 2001. This was the first gathering of people living with hepatitis B. It was conceived as a way for people to meet in person, to share their experiences and challenges, learn from each other, and engage with providers and scientists. We had 50 people join us at the first conference, and for very many people in the room, it was the first time that they talked about hepatitis B with anyone other than their doctor. It was a very moving and emotional weekend, and for some of us, it was a life-changing experience. We knew we wanted to bring the opportunity to others. We hosted Be Informed Patient Conferences from 2001 until 2019, and then COVID-19 happened, and we all learned how to use Zoom. This broad access to technology now means that we can bring the Be Informed Patient Conference to people around the globe in a cost-effective and meaningful way. As you will see today, these conferences are unique in that they bring together diverse experts from the lived experience community and the clinical and research and public health communities as well. In this way, we share important knowledge and perspectives among all of the key stakeholders so that we can more effectively collaborate into the future. We hope that everyone in this virtual room today will have a chance to engage, ask questions, share their thoughts and experiences. And we hope that you find today to be inspiring and helpful. I would like to thank our speakers for being with us and sharing their expertise. And thank you to Dr. Catherine Freeland, Associate Director of Public Health, for leading the conference. I would also like to thank Michelle Liu, Anusa Qureshi, the communications team, and the entire HBF staff for making today possible. Thank you today for our sponsor, GSK, for helping make this event possible and for allowing us to offer this conference simultaneously in English, Mandarin, French, and Spanish. As you know, strong voices make change happen. So we invite everyone here today to join us in whatever way you can, whether it's sharing your story, attending events, signing on to advocacy letters, supporting our efforts, or partnering with us. Please reach out if you're interested in joining. Next slide, please. I am very pleased to share our Be Informed Training Hub. This is a free online resource and a platform where anyone in the world can learn more about hepatitis B, Delta, and liver cancer. There are core modules on transmission, prevention, treatment, etc. There's quizzes at the end of each module, links to videos and other resources, and for those who complete the core modules, you can download a free certificate that certifies that you have completed training and can educate others. Next slide, please. I am also very pleased to just share a few of our additional resources. The resources that we have through the Hepatitis B Foundation are multi-platform. So we have resources that you can read or print out. We have audio, we have video, and we also have information in over 16 languages. So please make sure you use our resources. They are free to use and free to share with others. Next slide. I think we did this community poll already, Catherine, so I think we could probably either move on to the next slide or do the next poll. All right, with that, I'm going to hand it back to Dr. Freeland.
Thank you so much, Dr. Cohen. At this time, I'm going to welcome our first speaker, Dr. Sue Wang, who again is the medical director for the Chinese medical program at Cooperman-Barnabas. She's board certified in medicine, in internal medicine and pediatrics, and primarily specializes in adult primary care. We'd like to welcome her to share a bit about understanding the science of hepatitis B and D. So Sue, I will hand it over to you and just make sure that you're able to share your screen.
Great, thank you, Catherine. All right, give me a second to share my screen. All right, are we good? Catherine, can you see my screen?
Perfect. Yep, looks great.
All right, well, thank you to the Hepatitis B Foundation for having me here and for organizing what I think is a really unique meeting for people living with Hep B and those who are affected by hepatitis B. I think it's so important that we have physicians and researchers and scientists and patients all together talking about hepatitis B. And I want to start off by giving you a glimpse of my own story. So many of you know me if you've been in the hepatitis B field for a while, and you know I'm a dual citizen. So I'm both a practicing physician taking care of people in primary care and hepatitis B, but I'm also somebody living with hepatitis B. So let me just start off with my own story. My parents, starting from the left, my parents immigrated from Taiwan to the United States. And my grandparents, interestingly enough, in Taiwan worked in healthcare. One was a dentist and the other one was a midwife. And we found out later, actually, once they'd already retired from their jobs, that both actually had hepatitis B, though we don't know how exactly they got infected. But we know, obviously, prior to vaccines, it's been very endemic in Taiwan and much of Asia. So I discovered I had hepatitis B when I donated blood in college. And while an undergrad in medical school, I got my hepatitis B kind of checked sporadically. It wasn't really something I thought much about or really kind of tried not to. But when I met my husband and we started dating and then got married and then started having children, hepatitis became much more of a concern to me because I wanted to prevent transmission. He had gotten vaccinated early on, but once I got pregnant, I started getting my hepatitis B test much more regularly. And during pregnancy, found out my viral load was low, so I did not need treatment at that time. And each of my kids, my 4 kids, got the hepatitis B vaccine and the immunoglobulin within 12 hours of birth, and thankfully are hepatitis B free. So as a mother, I feel like it's a real relief just to know that they are not going to have to worry about it as I have had to their entire lives. And we really hope for a hepatitis B free generation. So now combining medicine, my lived experience, and advocacy has really been core to my work. And I think events like this really kind of epitomize where we need to go to make further progress in giving the next generation a hepatitis B free future. All right, so now moving into my talk. Even though hepatitis B is one of the most common infections in the world, there's such a low awareness about it. Globally, almost 300 million people live with Hep B, which is almost 10 times the number of people living with HIV. And in the US, we have more than 2 million people alone, and more than 50% are Asian, 50% are African, but it affects people of all backgrounds. And I think this WHO map is just really interesting in showing like where hepatitis B is endemic globally. And these are the populations that affects all around the world, right? So in the US, these communities of immigrants from Africa, from Asia and Southeast Asia are where we're seeing really high prevalences of hepatitis B. So this is a snapshot of hepatitis B. I know most of you already know these things, but I think it's important for us to start with these basic facts so that everybody's kind of on the same page. Hepatitis B is a virus that infects the liver, can become chronic. If it's not taken care of, it can lead to liver cancer, cirrhosis, and other problems. Is unfortunately still the leading cause of liver cancer worldwide. And the WHO put out numbers for 2024 in the hepatitis report from this past year, and it's still growing. You would think that we've turned the corner, but unfortunately, liver cancer from hepatitis B is actually still on the rise. But the good news is that we do have a safe vaccine that can prevent hepatitis B if you haven't been exposed, and we have really effective treatments that are safe and very effective at suppressing viral growth. So all of us here with hepatitis B, we can lead really long, healthy lives. I'm going to talk real quick about Delta. What is hepatitis Delta virus? You may have heard about it, but many of you have not heard about it. So this is just some basics about what you need to know. 5 to 10% of people with Hep B also have co-infection with hepatitis Delta. Delta actually requires hepatitis B to replicate, so only people with Hep B can get Delta. Delta actually then suppresses the hepatitis B virus and becomes the main source of liver damage. Delta can lead to a more severe form of hepatitis B, and 70% of people with Delta will have cirrhosis or liver cancer in 10 years if there is no intervention. The regions of highest prevalence include Mongolia, the Mediterranean, Middle East, Amazon Basin, parts of Asia, and parts of Africa. If you haven't been screened for Delta and you have hepatitis B, ask your doctor to do the HDV antibody test, the Delta antibody test, and if positive, of a HDV RNA test. And it'll be really great for us to hear also from one of our storytellers who has Delta, and that's something I think has been really important, is to hear from the voices of people living with Delta virus as well. So the great news is we do have all the tools to eliminate hepatitis B by 2030, which is the WHO goal. And we're doing great with things like vaccination, which you see up top here. You know, we're close to reaching the targets with vaccination, blood safety, injection safety, but we're really still quite behind when it comes to hepatitis B diagnosis, and even further behind when we talk about hepatitis B treatment. So we still need to really find the missing millions and get people linked to care and treatment. And if you aren't aware, at least since last year in the US, the CDC now recommends all adults get a one-time hepatitis B test, regardless of risk factors or where you were born. So make sure you let your friends and family know. So next, I want to dive more into the secret life of the hepatitis B virus. What is happening that's unseen by us from the outside, but is happening inside the liver and with our immune system. So this is the lovely graph of the stages of infection, which is quite complex. And if you ask a scientist about hepatitis B, you basically get a whole lot of these lines, and it's quite complicated when we talk about the natural history. But it's very interesting for those of us who are doing the work because hepatitis B is so complex and it changes. It's extremely dynamic. But to be honest, we don't need to know all of this in terms of being able to take care of people with hepatitis B. What's really important is just the concepts. So I'm going to give the next set of slides credit to Thomas Tu, who's a scientist many of you know, and he also runs an amazing Hep B community group online. If you haven't been on it, check out hepbcommunity.org. It's a great forum for people with hepatitis B with a lot of great insight from clinicians and scientists as well. But I think he's developed a really great way of understanding a complicated virus in a more easy way to understand. All right, so what is hepatitis B virus? Is it alive or dead? Well, it's a little bit of both, and this is a great metaphor. Let's think of hepatitis B virus like a seed. It has the potential to grow into a plant or a tree. So at the start of the infection, which can happen obviously when you're an infant or even an adult, when you're infected with hepatitis B at the start, you get these seeds, and they're traveling through your body and they meet the liver. And that's basically where it likes to embed itself and start growing. This is what happens. And the first thing hepatitis B does is it forms cccDNA. It sticks its roots into the liver, and from that, it sprouts more of itself, more of the hepatitis B virus, and those seeds that come from these newly infected cells go on to infect neighboring cells. And these seeds that come from the newly infected cells go on to infect other cells. So we get a whole lot of production of cccDNA and virus, and this allows the cells to keep producing other proteins from the virus. In this case, this also includes surface antigen. So the leaf here that you see is a surface antigen that is a protein that comes from the virus. It's what we see in the bloodstream, but just so you know what's happening in the background, it's actually just a protein coming from the virus. All right, so the first phase, what we call immune tolerance in some circles, is the first phase in immune tolerance, and this is what happens when the entire liver is infected with hepatitis B. So it's producing a ton of seeds, a lot of surface antigen, but if you look carefully at the liver, the trees are not actually harming the liver, or at least we can't, it doesn't seem that it is. And there's very few symptoms or inflammation when you're in this phase, so the liver enzymes will be completely normal. When somebody's truly in the immune tolerance phase. All right, so what happens in the next phase is that the immune response starts to recognize that, hey, something's not right, and it's time to clear out these infected cells. And this is when we go into the phase 2, or immune active or immune clearance phase. And the immune system here is shown as a kind of a bulldozer, and it's trying to get rid of these infected cells, and all this fire is indicative of the immune activity. What's happening now is the immune system is trying to clear the virus and these cells that are infected. And what it also starts to do is it starts to cause some problems with your liver, and you see the elevation of your ALT and AST. But you do see that it is actually getting rid of some of the virus. And so if it's successful, you will actually see that it decreases the amount of viral load DNA. It will be lower. And you will also see that there's a calming, right? So some of these hepatocytes don't have the fire going on, and so there'll be a decrease in the ALT. So what happens is, unfortunately, even if the ALT goes down, ALT and the viral load go down, the virus is very tricky. It learns to produce new forms that only produce surface antigen. And because surface antigen is a protein, it allows the virus to hide from the immune system. And the response of this to the surface antigen of the immune system seems to block the view to the virus of the infected cells. So it becomes, so it cannot clear every infected cell. And there's still more of that cccDNA, these roots in the bottom still remain, even though you have less virus, you still have a lot of surface antigen, and the roots are still there. So, and John Tavis, who's a virologist, can explain this even better. But this is basically a layman's term of what's happening. All right, so we're going to move on to phase 4, which is immune escape. And you see here, there are new trees that have sprouted from the cccDNA, and these new seeds also are produced, and you get variants of trees. So we often will talk about mutations that have happened, and basically the virus has learned to escape the immune system, the immune control. And these infection events and seeds can now infect new cells, and they start to produce new viruses. And all over again, we get the immune system recognizing these, and inflammation restarts. So somebody may have had a very, quiescent, calm time where everything seemed inactive, but then they can start reactivating too. So this is why we always tell people, your viral load may be low now, but you have to keep checking with your doctor every 6 to 12 months, because you can develop this immune escape and you can completely feel fine, but we won't know until we actually check your blood work what's actually happening. So here you see ongoing liver inflammation, more virus in the blood, and just over time, this inflammation leads to increased risk of cancer and liver disease. So what we are, okay, so I'm going to go only very briefly into like current treatments and what we're talking about. And Dr. Tavis and Dr. Block will go really dive deep into, what's happening with curative therapy. But I think in terms of like matching up what I've just been talking about with treatments, this is interesting. So what we have currently is that we can cover the liver and stop the virus from producing new virus with the current nucleoside therapy that we have. So, however, even though we can get rid of Hep B DNA, the infection, so you see basically there's less of the seeds, but there's still a lot of leaves. So we still have a lot of surface antigen, and the roots are obviously still there too. So that's why we say, even though you've cleared the virus, you still have parts of the infection still inside the liver. So what are some of the approaches to curing the infection? How are we going to go about trying to cure the infection with new drugs? Well, they're kind of three different ways, and the ultimate cure will probably be a combination of these strategies. So the first is to try to remove the underlying infection, including the cccDNA, so we get completely uninfected cells. Already now in the liver, this is really hard, and so there are basically, we're looking for a way to stop the virus from producing new proteins or leaves or seeds. Okay, and then secondly, we'd like to find a way to suppress the virus protein production, where the cccDNA may still be there and maybe suppressed, but we can still actually, and we might be able to create an incomplete cure, but still functionally active. So I'm not going to go into this too much because I think this might, this will be explained more. And the other way is to activate the immune response. So, and this will be some of the immunomodulators and the vaccines that basically help wake up the immune system, see if we can more effectively clear the infection. All right, this is just kind of the blood tests that we use and what they reflect in the images that I was just talking about. All right, so I'm a primary care doctor. I do a lot of work in hepatitis B, and I hear lots of talks at scientific meetings. Sometimes I don't understand a lot of what they're saying, but I do over and over again, things start to sink in. And I think for some of you guys, you may be feeling this, that a lot of this is new every time you hear the scientific presentations. But trust me, the more you expose yourself to these kind of presentations, it's increasing your understanding of hepatitis B. We really need people with Hep B in the engaged community to kind of understand more and more of this, because oftentimes we ask questions that scientists don't often ask, right? And we need to be at the front of the discussion and be at the table when we're talking about therapy. So I encourage all of you guys to keep learning because it's so important for us to have engaged patients to help drive change. So I'm going to share a couple more things that I think are really interesting, and I think this from a patient perspective about what we're learning about the secret life of Hep B. So T cell exhaustion happens with long-term Hep B infection. I found this fascinating. And actually, as I heard more about this, this is one of the reasons I myself started taking hepatitis B medication. And it just kind of is another way of understanding like what's happening with the immune system. So T cells are part of your immune system. They're a white blood cell called a lymphocyte, and they help fight off infections. So with long-term Hep B infection, we do get a gradual loss of Hep B specific T cell function. And as this continues, they become unresponsive. And when this is very severe, the T cells can actually be deleted or they can die. So next, another thing that we are finding is interesting is with the Hep B infection, the virus actually integrates itself into the host DNA. And this happens randomly to infected hepatocytes. And these integrations also randomly can have mutations. And these mutations may lead to a growth advantage, which leads to clonal expansion. And the clonal expansion of these hepatocytes often are selected for cancer growth. The malignant ones often replicate more. And this is how liver cancers can occur in non-cirrhotic livers. So next, I found this cohort study to be really interesting. This is a large-scale cohort study in China that showed that people with Hep B, it wasn't just really high rates of liver cancer, which you see has a higher hazard ratio of 15, which is very, very high, but overall cancer rates were higher with a hazard ratio of 2. And when you look at which cancers were more significant, it included lymphoma, pancreatic cancer, oral cancer, colorectal cancer, stomach cancer. I think for many of us living with Hep B, this is very concerning. And it's really not just about liver cancer, but there are other issues that come with the virus that may drive us to want to treat our hepatitis B earlier. So what I'm going to talk about earlier is getting hepatitis B care and treatment. So even if you feel perfectly fine, and most of us do, it's very important to take care of your Hep B. There's a lot you can do. You can do
Thanks everyone for letting us know. I believe we lost Sue, but I'm gonna just send her a message now to try to get her back online with us. Thank you for your patience.
Sue, are you back, I think?
Yeah, that's weird. I froze. I guess I just saw that it froze.
Yeah,
Was I out for a while?
just like a couple minutes, I would say. And I think if you could slow down just a tad for the translators, I think that would be great.
Oh, thank you for that reminder. Okay, so tell me which slide I was on.
This one, yeah.
Okay. All right, great. So this was basically just a summary of how important it is to stay in care for hepatitis B and making sure that even if you feel fine, that you get your hepatitis B tests every 6 to 12 months, sometimes even more frequent, and that liver cancer screening is important. So you can get ultrasound, AFP, or sometimes there's other imaging like CT scans. So this is the summary of kind of overall care of hepatitis B. All right, and then this is just an important reminder of how hepatitis B is spread. It's spread through blood and bodily fluids, but not by casual contact like hugging, kissing, holding hands, or sharing utensils. There's a lot of myths and misconceptions that happen from that often lead to stigma and discrimination. So we just want to make sure that's really clear out there. So people with hepatitis B can participate in day-to-day activities, including contact sports. They can share food and utensils and eat with people. They can pursue all educational career opportunities without limitations, and they can also work as healthcare professionals. So discrimination based on Hep B status in the US is illegal, and but worldwide, we want to hear about any discrimination events, and the Hepatitis B Foundation has a great registry. And so if you hear or experience any discrimination, we definitely go online and fill this form out on the Hepatitis B Foundation so we can collect this information. So next we're going to move into Hep B treatment. These are the FDA-approved drugs for Hep B, and the three in purple are the first line treatments that are mostly being used, the ones mostly being used these days, and these are all oral. So we have entecavir, which is generic, abbreviation is ETV, brand name in the US at least is Baraclude. We have tenofovir disoproxil fumarate, or TDF, and we have the newer version of tenofovir, which is tenofovir alafenamide, or Vemlidy in the US, and this is the newest one, approved 2006. And then these other second or third line treatments we don't really use as much anymore. All right, so are you having problems getting Hep B medication? I mean, a lot has changed globally, where the generics are much more widely available now. And they are very low cost globally, although we know that to patients, sometimes there's many barriers in accessing it. And so it's helpful, I think, as a patient community for us to share tips and things we find out. In the US, one of the important things is that you don't always have to go through your insurance. Sometimes the insurance will give you a harder time and it's more expensive, but you can actually get the generics directly from a pharmacy, and you don't need insurance, but you do need a prescription from your physician. So you can go online to any of these. GoodRx has coupon codes where you can get meds from grocery stores, and we were able to find that for TDF, you can get it for $18 a month versus from the insurance company, sometimes it's almost $300. There's mail order pharmacies, and we found a price for entecavir for $76 for 3 months. And so it's definitely worth looking for and not overpaying for it. So it's just like, why are medicines so expensive? And there's just so many middle people before it gets to us as a consumer. There's the drug maker, there's the wholesaler, there's the pharmacy benefit manager, the pharmacy itself. They each take a cut of the profit. And so the end result, unfortunately, is that it does get passed down to patients. So how do we decide who should be started on Hep B treatment? A traditional approach over the years has been to try to treat when we kind of have this battle, as you see this image of the horses, like the immunity and the virus. And basically when we see inflammation, that's been a marker for us as to when to treat. And this diagram is often circulated in the scientific community too. So you see there are like different liver societies. There's the American ASLD, there's the Asian APA PALSL, and there's the European guidelines. And if you kind of look, everybody agrees to treat with people who are cirrhotic, but if you don't have cirrhosis, you can see the cutoffs are different for viral load when you treat if somebody's E antigen positive, E antigen negative, and how high the ALT should be. And so this is like over time been a little bit confusing for people in the community to follow. This is just a snapshot of a number of the guidelines and the cutoffs for DNA ALT for treatment. So, but there is a movement towards simplifying guidelines, and I'm going to share about the WHO guidelines, which just came this year. And this is exciting to see because instead of trying to stage somebody and do the E antigen and figure out if they're in the immune tolerant phase, immune active, or gray zone, now these criteria are totally separate from that. So you no longer need the E antigen to be eligible for treatment. And it's out of these 4 criteria, we have fibrosis, somebody's more than over F2 with an APRI score of over 0.5, or elastography over 7 kPa. Or if the viral load is over 2,000 and ALT is above upper limit. So it's no longer that 2 times or 1.5 times of upper limit. And then third and fourth ones, this is basically doesn't even matter what the viral load is, but if somebody has a co-infection like HIV, Delta, or Hep C, they have any family history of liver cancer or cirrhosis, they're immunosuppressed, or they have other comorbidities such as diabetes or MASLD, the metabolic associated liver disease, or other extrahepatic manifestations. And in areas when there's no Hep B viral load, just having abnormal liver enzymes alone is an indication that you can start treatment. So I think that's really important because so many areas of the world with hepatitis B, you cannot get a viral load test. So we've seen this interesting algorithm come out from China, simplifying even more, where we're not even looking at 2,000 cutoff, but any detectable DNA if you're over 30 or with any of these, or under 30, but you have any of these co-factors like cirrhosis, you could start treatment. So this is interesting, and I think it's important for us to share these because it just shows you there's not one right answer, and that clinicians do have some kind of leeway in terms of deciding. So also Hep B Foundation this year released what I think is really important, a statement backed by hundreds of clinicians and people in the community, the call to action that we really need to expand hepatitis B treatment. And this is not to replace the society guidelines, but to bolster it and to supplement it so that we don't have as many people falling through the cracks. So take a look at this online, but basically we're saying if a patient wants to be treated, there's no reason that patients should not be allowed to be treated. So who decides whether to start treatment? Is it the doctor or the patient? So importantly, let's remember it should be both, where we have shared decision-making that combines both provider, clinical experience, and recommendations, along with evidence-based medicine. And very importantly, in the middle of it, patient values and preferences should be part of this decision-making as well. So I want to also talk about how important it is for us to look at patient-reported outcomes and to look at things that are important to patients with hepatitis B, not just the viral load, not just the liver enzymes. And Hepatitis B Foundation did a survey of PRO of patients taking medications. So what benefits did people with Hep B feel like they received from being on medication? So in the US, the top 3 reported benefits were 1, being less worried about a shorter life, 2, being less afraid of getting liver cancer, And interestingly, number 3 was not worrying about transmitting the virus. So of the international respondents, the top 3 were 1, not having to avoid others, 2, feeling shame or stigma, and 3, feeling less tired. So these are things that clinicians don't always think about, but obviously are very important to patients and really needs to be part of our decision making, but hasn't been so far. So I think we're hoping that we can incorporate such measures in the future as we do research, clinical trials, and also in how we practice medicine. So this is about all I could cover today, but I hope that you see how important it is for us to continue to learn more and be engaged. And what I often say is that we have a real opportunity here because of the really large numbers of people living with Hep B, almost 300 million of us. If we could harness the power of all of us and get more people diagnosed and engaged and activated, we really have a powerful force of people that could demand access, improve care, create support, propel research, and inspire innovation, ultimately be a part of saving lives. So I hope all of you will join us as we amplify the patient voice and make change. Thank you. I'll pass it back to you, Catherine.
Thanks so much, Sue. Just a quick question that came up a couple of different times from some of the folks. There were a lot of questions about stopping treatment. Do you have any thoughts on that or suggestions for folks living with hepatitis B around the world, and what kind of advice you might suggest to them?
Yeah, that's interesting. I think, at this point, our recommendation is for the near future that there's no recommendations to stop treatment that are clear. There's a lot of studies showing which patients who do stop treatment have kind of a sustained response and don't reactivate. And there's certain like risk factors. Asian people tend to kind of reactivate more. And looking at the quantitative surface antigen level is a way to help decide who can stop and who shouldn't stop. So if the quantitative surface antigen is less than 100, there's a better chance that you'll do well. If it's really high, then you shouldn't even think about stopping. I mean, I know this test is not available widely yet, but we have certain, that's one of the things that they're using to help us decide who might be a better candidate. But if you do stop treatment for whatever reason, it's really important to get your blood tests more frequently in the initial phase, because we need to make sure that you're not flaring, that your liver enzymes aren't going up, or your viral load's not, going up significantly. And if you have symptoms, definitely please go, see a doctor, because there are some cases of people having hepatic flares or even going into liver failure when they stop.
Thanks so much. And then another question about alcohol consumption. Any sort of recommendations on that for somebody living with hepatitis B?
I mean, the general message is, once you already have Hep B, we tell people you want to protect your liver. You want to avoid any additional insults to your liver, right? So we even say, be careful taking dietary and herbal supplements, because a lot of them do inflame the liver worse, and you want to make sure your doctor knows about it. Alcohol obviously is another insult to the liver. So when we tell people, if you can't, abstinence is ideal, but if you can't, at least limit your amount of alcohol. So I often will tell patients, just drink very little or drink very slowly. But it's, as much as you can limit it is ideal.
Thank you so much, Sue. I mean, there were just comments as well.
Yeah, I'll try to respond to some of them too. Yeah.
Yeah, awesome. Any recommendations on dietary supplements or anything like that?
So I think it's good to be cautious. There are a few, milk thistle is one of the few that we can say there are some positive studies on it. There's nothing that's going to be curative. Like there's a lot of people online saying that they have the cure to Hep B. If that was the case, we would all be, we'd be in a different place. We wouldn't be having this conversation. So just be cautious when you hear people say they have the cure to Hep B and it's in a supplement. Those things have not been really tested. And I think it's really important for us to realize what happens in a clinical trial, which I think John Tavis will talk about, and how rigorous it is. And things that are sold as supplements and don't go through that kind of rigorousness at all. So we often are very cautious, and sometimes there's contamination that happens. People get into worse problems with their liver when they're buying things that haven't really been cleared or inspected. So yeah, great question.
Thank you. And then last, just note, maybe you can comment on this as well. Dr. Block put in the chat to be mindful that some prescribed over-the-counter drugs may aggravate hepatitis B. Any thoughts or additional comments for clarification on that one as well?
Yeah, I mean, there are some things that cause elevation of liver enzymes. And so, for example, like statins are a very common medication we give people with high cholesterol. You know, the vast majority of people don't have any issues with it, and I prescribe it quite a lot. But occasionally somebody will have elevation of liver enzymes from it. And so, you know, for those people, especially if they have Hep B, then it kind of muddles the picture. So we might switch their medication to something else. Yeah, so I think you just have to be, you know, you do have to be cautious of some of the interactions. But for the most part, people with Hep B can, you know, take almost all the same medicines that everybody else. You can take acetaminophen. You just don't want to take really, really high doses over a day, but you don't need to avoid it completely. Like I still take acetaminophen for headaches myself. So, you know, I don't think people need to stay away from it completely.
Thank you. And then, sorry, we just got one other good one that I think we get a lot. After completing the hepatitis B vaccination, is it advisable to live a normal life with your partner?
Yes, definitely. I mean, I think this is why the vaccine is such a life changer, for a game changer for all of us, is because once you're immune, you cannot get hepatitis B infection. And, you know, when my husband got vaccinated, it was just, you know, just very liberating. You just realize that you don't have to worry about infecting your loved one. And same with our kids too. So I think, yeah, we need to really talk about hepatitis B vaccination. A lot of times people aren't being offered it enough. And there are obviously people who are at higher risk, like I think healthcare workers or frontline workers, if you're exposed to blood, and people, you know, in household situations, if they live with somebody with Hep B or our partners, you know, vaccination should be the first thing that you do. And, you know, just as it stops the transmission. So it's great.
Great. Thank you. Thank you. And there are a lot of comments in the chat. We'll do our best to get to those as well as we move through the session. Thanks so much, Dr. Wong, for your excellent presentation. I think it was a great start, and I'm sure there will be other questions throughout as we end the presentation section. So with that, I'm going to welcome Dr. John Tavis, who's a professor of molecular virology at St. Louis University in St. Louis, Missouri in the US. He studied the hepatitis B replication mechanisms of HBV and the biochemistry of the viral reverse transcriptase since 1992. He serves as the chairman of the Scientific Advisory Council for the annual Molecular Biology of the Hepatitis B virus meeting, and as a member of the Council for Extramural Grants at the American Cancer Society. His current work focuses on developing novel drugs to suppress hepatitis B replication that target the essential viral ribonuclease H enzyme. Welcome, Dr. Tavis. We can see your slides. It looks great.
Excellent. I'm pleased to hear that. First off, I want to thank the Hepatitis B Foundation for inviting me to speak today. It's always fun doing those sorts of things, particularly with the good friends that I have on the presentation panel. Another thing that I want to do is to just emphasize some comments that Sue just made. That vaccine is one of the best ever produced by science. If you haven't been vaccinated, I strongly encourage that you go do it. And then the second, excuse me, is scrolling through the chat as we were going on. There were a lot of questions about interpersonal relationships and things like that. I am not HPV positive, so I cannot comment on them. But the online forum that Sue mentioned, hepbcommunity.org, is an absolutely superb resource for people who are living with HPV, their loved ones, and also the scientists and caregivers and medical professionals. So I frequently participate in that, answering people's questions. So I really encourage people to go look at that. But today, my topic is something I talk a little bit more functionally about, is because I'm a massive virus nerd. I love viruses. They're just so fascinatingly interesting. And so I hang around in a lab and I muck about with viruses. And so today I've been asked to talk about what is a functional cure and how can we get there. And so let's dive right on in. So, okay, so again, real quick virology review for the portions of this talk, the virus biology that's important to the talk that I'm going to be giving here. First off, HBV is a partially double-stranded DNA virus. Scientifically, it's very interesting, but that's just how you would go about describing it if you're a virology nerd. It replicates in the liver, and it uses a process called reverse transcription that copies an RNA copy of the viral genomic information into DNA. It chronically infects somewhere around 250 million people. That is a typo. I'm sorry about that. I'm one of the world's worst proofreaders worldwide. Causes acute and chronic hepatitis. And that hepatitis can proceed through various stages of fibrosis to cirrhosis, liver failure, or liver cancer. And it causes around 1.1 million deaths annually based on the latest WHO data. Hepatitis delta virus, because I'm going to bring out that a little bit too, because the two are so closely intertwined in their biology. It's a circular RNA entity. It's not even a real virus. It's something, the thing it's closest related to is something called a viroid, which are really, really common in plants. It replicates in the liver, and it uses human enzymes to do that. So it really, takes advantage of the components of your cells. It is always found in association with HBV because it needs the HBV surface protein, or HBS, or HBsAg, abbreviated a number of different ways, to spread between cells. So it can replicate by itself within a cell, but it can't get to the next cell without having HBV around. And about 5% or so of people with chronic HBV also have chronic HDV. Those numbers are very, very poor. We really don't know the exact number are associated with them because there's not a lot of screening done for it, and the screening tests have some pretty big problems with them. And so those numbers are really have a lot of uncertainty associated with them. And the biggest problem is that having HDV together with HBV makes hepatitis B much worse. So the replication cycle, I do need to get into this a little bit because we're going to be talking about drugs, and the drugs are going to be targeting various aspects of the viral behavior. So what you're seeing here is this big kind of gray box with rounded edges. That's a hepatocyte. And so the virus binds to the outside of the hepatocyte, enters, it dumps its interior component into the cell, and then that goes through to this gray circle here, which is the nucleus, or the center of your cell. It's the control or command center of the cell. It's where your cell's DNA is. And it takes its DNA and dumps it in there. And then it takes that partially double-stranded form, converts it into a properly behaved piece of DNA called a covalently closed circular DNA. That then becomes biologically active, and it makes 4 different classes of RNAs. Those go back out into the cytoplasm. They're all messenger RNAs, which means they can tell the cell to make proteins. And so that's what they do. So a bunch of proteins build up, and then 2 proteins and one of these RNAs get together to form a well, you can call it a baby capsid. Okay, it's a capsid with just RNA in it. And then through a 2-stage process, reverse transcription occurs, making that partially double-stranded DNA in there. Then the virus can be secreted or kind of spit out of a cell. This doesn't really hurt the cell at all. And so it goes through and it picks up its membrane and gets spit out of the cell. In some cases, that capsid then goes back into the nucleus, and drops its DNA back off into the nucleus, making more cccDNA and completing an intracellular circuit. So there's 2 circuits maintaining HBV. One's an extracellular circuit where you see this virus that was just made can loop around and start the process in a new cell. So there's a loop right there going around. So that's one circle. Okay, and then there's another circle inside your cell. But importantly, all of the viral replication leading to the cccDNA, which is the master copy of the viral genome that's essential for persistence of the virus, is made by reverse transcription. And that's a key point to know when we start talking about the drugs. Okay, so our current therapies, Sue went through this quite well. I'll dive into it just a little bit more. For HPV, you've got pegylated interferon alpha. The way that works is it tells a type of your immune system called the innate immune response. Those are oftentimes a type of white blood cell going on or other things. It tells it to go attack HPV in your liver. Okay, so that helps. It suppresses the virus. Unfortunately, the side effects from interferon alpha in some patients can be quite serious. And you can get long-term health improvements of following treatment in less than 30% of the patients, who are treated, if you take the entire population. And it very, very rarely cures HPV, but it can every now and then do that. Then you've got the nucleoside nucleotide analogs. They directly block DNA replication. They block that reverse transcription process that I mentioned in the previous slide. These are usually very well tolerated in almost all patients. There are side effects of them, but your physicians are very good at managing them, and they've got multiple drugs, and so you can move around when they cause problems. And so they are really very good drugs. However, they don't cure the virus very often, so it generally leads to lifelong treatment. And importantly, it improves liver health in almost all patients and really reduces the risk of transmission, because the risk of transmission is related to how much virus you've got floating around in your bloodstream. But also the nucleoside analogs rarely cure HPV. They do it even less often than pegylated interferon does. So it's really more of a maintenance therapy to keep the virus under control and reduce the disease. And those are the only two we got right now. Then you've got hepatitis delta virus that is treated with two different types of drugs. One is pegylated interferon alpha, again, that does the same thing, triggering host immune responses. In HDV, the side effects can be very severe at times, and it very, very rarely cures HDV. It was used for a long time simply because it's the only thing we had. Recently, quite excitingly, there's a new drug that's been approved. It's been approved in Europe and is, I believe, in phase 3 clinical trials in the United States. Its generic name is Mircladex B. It's also known as Hepcludex, or I always mispronounce this name, bulevirtide. Yeah, I think that's about right. And that blocks HBV and HDV entry into cells. Again, it's usually well tolerated, and it improves liver health from hepatitis D infections in most patients. It can cure the infection, but it is relatively rare for that to happen. So again, what we've got now is some fairly decent drugs against the virus, but they don't cure the infection. And that's a problem for people living with HPV. So there's a lot of work going on in the world right now trying to develop curative HPV and HDV therapies. I mean, it is a truly large, enormous amount of work, and the amount of money that is being spent on trying to cure these viruses is tremendous. It really is a large amount. So the general goals of this huge effort that's happening in drug companies, it's happening in universities, it's happening in research institutes such as the Blumberg Institute that is run by the Hepatitis B Foundation. The general goals are to cure the infections. That's the primary goal. Let's cure the infection and get those viruses out of there. And that will stop and hopefully reverse disease progression. The human liver has a remarkable ability to heal itself. And so if we stop beating up on it by getting rid of HBV or HDV, the liver will start fixing itself. It might be slow, but it can actually reverse some of the disease and regain health. And so that's a really optimistic thing to think about. Also, of course, as that poll that Sue talked about says, it stops transmission to other people. If you don't have the virus, you can't give it to anybody else. And it also would eliminate the side effects from indefinite drug therapy. The side effects aren't large, but they're also not zero in some people. So, there's a lot of general goals there. And so the scientific and medical communities have settled on something that's called a functional cure as the target for an achievable means of, a scientifically and medically achievable way of achieving those general goals. It's called a functional cure. And so I like to start with the biological definition of that before I get to the medical definition, because the biological definition really explains why we want to do it better. First off, it leads to no actively replicating HBV in the liver or detectable HBV DNA in the blood. Okay, so that's a good thing. And that's after the drugs are stopped. Next is immune control of any residual HBV in the body, because you don't always get rid of HBV, even if you clear an acute infection. There's oftentimes a little bit of it hanging about in the body yet. And then, of course, there's no disease progression or risk of transmission at all. So that's the biological definition of it. But you can't measure all those things. Okay, you certainly can't conveniently measure them in a patient. And so it's got a medical or a clinical definition also. And that is undetectable HBV, DNA, and hepatitis B surface antigen, or HBS, in the blood 6 months post-treatment. Okay, that definition it sounds straightforward, but actually determining whether or not it is real is a problem, because the diagnostic assays for HBS can be fooled by that integration step that Sue mentioned briefly in her presentation. So we've got a biomarker problem here that is making us having a little bit of difficulty in telling when somebody truly has achieved a functional cure. But it's the best we can do right now. There are people working hard on it, but that's the best we can do at the moment. Okay, so what do we need to do to cure HBV? And again, Sue foreshadowed this in her presentation. The first thing that we need to do is profoundly suppress HBV replication. We really need to wail on that virus very hard. And although the nucleotide analogs do suppress the viral replication very well, and it's oftentimes below detectable, it's actually usually below detectable in a treated person's blood, it's important to remember that undetectable does not mean not there. All tests, all assays have a limit of sensitivity. And even with the most sensitive assays, there can still be some virus still floating around in the bloodstream. And so scientific studies have demonstrated that that's true for HBV, is that somebody who has no detectable HBV in their blood by the clinical assays being used still can have DNA replicating in the liver. It's at a very low level, but it doesn't mean it's not doing it. And so what's happening there is, remember those two circles I showed in the cellular replication? The cccDNA keeps getting replenished. And so the virus doesn't go away because it keeps getting restored by that low level replication. So we need to improve how hard we're hitting viral replication. The second thing that I personally am starting to appreciate much more than I did not long ago is we need to reduce HBV protein accumulation. And proteins in the blood from a virus are called antigenemia. So we need to reduce HBV antigenemia. And the reason for that is both HBS and the HBE proteins are immunosuppressive. Immunosuppressive means that they stop the white blood cells. They stop the immune system from working the way it's supposed to. It gets in the way of the immune system doing its job. And so that's one of the main reasons why HBV persists in chronically infected individuals. And so reducing those levels will remove a block to immune control of the virus. And so that's important. Then we have to activate immune control of the residual HBV in the liver. And the reason we have to do that is elimination of the HBV cccDNA. That's that master copy of the viral DNA that can drive all of HBV replication. Does not occur even after clearance of acute infections in some patients. We don't know if it's in everybody or if it's just in some, but we do know that in many patients who appear to have cleared HBV, gotten it out, there's some hanging out in the liver yet. And so that means that you have to have the immune system working to keep that trace amount of cccDNA under control. And the studies have come out that showing in most cases reducing HBV antigenemia by itself is important for restoring immune responses, but it's not sufficient to do it. It's not enough to do it by itself in the large majority of cases. And so that obviously implies a need for some form of an immune stimulating drugs. And in the current clinical studies, interferon alpha is being used most commonly to provide that role. And finally, we may need to induce some hepatocyte cell death. And the reason for that is the cccDNA is lost out of the cell upon cell division. So when a cell grows big and then it divides in half again, and that's called cell division, when it does that, the cccDNA gets lost. And so both of the cells that came from an infected cell end up being uninfected because they lost the cccDNA during the process of cell division. So that's great. The way that appears in patients being treated is oftentimes what's referred to as hepatic flares, where the ALT levels will shoot real high for a little while and then they'll come back down. That's coming from liver cell lysis or popping the cells open and killing them. And that is associated with killing. And it has a twofold effect, helping clear the viruses, because obviously if you kill a cell with HBV in it, you've killed the HBV that was in that cell. But also then the cells next to it divide to fill in that space, and both of those get cured in that process. So we may need to promote some hepatocyte cell death, but we got to be really careful about that. And of course, that's at odds with many regulatory expectations that drugs be as safe as possible. So there are things to think about there. Okay, so what are the challenges to achieving a functional cure? I mean, there has probably been, if I had to guess, maybe $50 to $100 billion spent trying to cure HBV so far, and we've only got one new drug, and that's Mircladex B that's been approved. Okay, and so yeah, what's the problem here? And the basic thing is this is a real hard thing to do. For HBV, the biological reasons are, one is the cccDNA is very stable. If something is degrading and being replaced in a constant cycle, it's easier to get rid of it by interrupting that cycle. But the cccDNA is a very, very stable molecule. And so that's a problem. You also can have very high DNA or high levels of replication of the virus in some people. Other people, it's very low, but the high level of replication can be a problem. And then you have this immune tolerance to HBV proteins, which means the immune system, whose job is normally to go get rid of viruses like this, can't really do its job very well. And so those are the biological reasons. Other reasons are underinvestment in basic and translational research. HBV has been known for over 50 years, and we still don't know some very basic facts about how it works. If we don't know those facts, how are we going to go in there and fix something to make the cells work better and to get rid of the virus? We have lack of basic knowledge, in particular about cccDNA metabolism, how it's made, and the details of how it's made and how it's broken down. And even lack of basic knowledge about how the immune system and its failure to work perfectly during infection is functioning. So we've got some serious gaps there. HDV, you've got, again, biological reasons, very high level of replication. There's very few viral targets to attack. It's such a simple virus-like thing that there's not a lot to hit. And you have very poorly effective immune responses. And the other reasons are very similar to what they are for HBV. We just don't know enough in some cases to know what to do. Okay, so HBV, what drug targets are available? There'll be more details on the drugs and stuff coming up in Dr. Block's talk here in a little bit. But the take-home message is what's in the slide. This is the same cellular replication cycle picture that I showed you earlier. I've just added arrows. Every place there's something that somebody is trying to hit the virus with something. And you can see basically everything on this slide has a red arrow pointing towards it. And so we have an enormous number of different targets that we can try and disrupt to inhibit HBV replication. So we're really fortunate that way. And there's been a huge amount of work done trying to inhibit various aspects of viral replication. So you can see, and this is part of the reason why the scientific community is fully convinced that we can cure HBV. It's just going to take a little while to figure it out right. Hepatitis delta virus, there it's a little more depressing. There's a lot fewer targets to hit because the virus is so simple. It encodes one protein. It doesn't have any catalytic activity. That means it doesn't cause a chemical reaction to occur. Much of its function is done by cellular enzymes. It's just there's not much to hit. So you've got a problem there. But I think what's most promising is because HDV is absolutely dependent upon HBV to get from one cell to another. If we cure HBV, we're eventually going to cure HDV. Okay, and the reason is because if you stop spreading the virus from one cell to another, eventually all the cells carrying HDV are going to die and are going to be replaced by cells that have divided and don't have HDV in them. And so you can cure HDV by curing HBV. And if I had to guess, I think that's the way we'll eventually get it done in most cases. Okay, so what are we looking about? I was asked to talk about, how do we get there? Well, how do we get to a combination therapy? How do we get to a cure? We're going to need a combination therapy, and that means more than one drug given simultaneously is going to be needed to cure HBV. And so the three big goals of HBV therapy is block replication, reduce antigenemia, and activate immune responses are most likely going to need different drugs because those are very different processes. Some drugs can do a little bit, 2 of them or something like that, but there's none that I'm aware of that can do all 3 of them. And so we're going to need multiple drugs together. And the other reason for that is giving multiple drugs simultaneously reduces the rate of resistance evolution. And so it means that the virus can't change itself to get around the pressure that the drug's putting on it. The drugs must have complementary mechanisms of action. That makes sense if they're trying to do different things. And that allows one drug to compensate for weaknesses in another drug. And ideally, they'll be synergistic. What I mean by synergistic is, for example, 1 + 1 = 3. You're getting more out than you put in. That means that they help each other. And the drugs, of course, must be compatible with each other. We're going to have to develop drugs that have dosing patterns that are ideally the same for simplicity of delivery. It is so easy to forget if you take a drug every day. I have high blood pressure and asthma. 5 minutes after I take my drugs in the morning, I can't remember if I did it. Okay. And so simplicity is important here. And they must not cause combinatorial toxicity. And finally, the combinations obviously need to be safe, but they also need to be affordable. And that's because drugs only work if people can actually take them. And if you can't afford them, well, the best drug in the world isn't going to help you. And so that's extremely important. So now, how do we get there? Because if we're going to develop combination drugs, that means we have to develop each individual drug itself and then find out which ones work well together. So how do we go about developing a drug? So you start out, and the starting point is what's on the left-hand side here. It's something called the target product profile. And that's when somebody who's trying to develop a drug, whether it be an industry or an academia, sits down and decides, okay, well, what do I want to do? And so they decide which disease they want to treat, which population of people that they want to treat it in, what type of drug do you want to develop? Is this going to be an oral drug, an injected drug, a topical drug that you rub on the skin? What are your goals? What do you want to get done? So for HBV, what that means is a functional cure. Risk definition and tolerance. Okay, how much risk are you going to be willing to put the patients at in the course of the treatment? And that, of course, depends upon how bad the disease is. If you're trying to develop a drug for cancer, well, killing the patient slower than the cancer does is considered a plus. But you can't do that for something like HBV. And then, of course, because this costs an enormous amount of money, price is always extremely important because the drug companies have to make their money back. Otherwise, they'll go out of business and they won't be able to make any drugs. And so here's what happens scientifically here is you start out with literally millions and millions and millions of different molecules. And you have a very staged, carefully designed process called a testing funnel that you, as quickly as possible, figure out which ones could possibly be good. And then of those, which ones of those are a little bit better? Which ones of those are a little bit better? And you go through this funnel, and the goal is to rapidly get rid of ones that are unpromising. Finally, you get down here to the clinical phase, which is here, and that goes through 4 different stages of development. I'll talk to you a little bit about that. And then there's the regulatory review down at the bottom. And that is when the drug regulating agencies, the European Medicines Agency or the FDA, those are just a couple of quick examples. They look at all of the data that has ever been generated basically on that molecule and its mechanism of action. And they decide whether or not it provides benefit to the patient, if it's safe enough to be used for the patient. And then it finally goes to the market and patients can buy it and use it. So this is the process. So in 2016, that took on average 2.6 billion US dollars. So this is incredibly expensive. My lab is working on something called RNase H inhibitors. We've gotten down to this stage where we're just entering into the preclinical phase here. We've spent about $10 million so far. And on this, the cost of these things just skyrockets as you get into the clinical phase. So this is a very expensive process. And go ahead and get mad at drug companies. I do it all the time. But at the same time, they're spending huge amount of money. And if they go out of business, they can't make drugs. Okay, so what happens in clinical testing? So again, there's 4 phases to it in a standard clinical trial, and each drug may go through multiple versions of this. So for example, you might have a phase 2A and a 2B study. That's very common to have happen. And so in phase 1, this is the first time a drug goes into human beings. And its only goal is to figure out if it's safety in healthy people. That's what you're doing there. And they're usually escalating dose studies where you start out and you give a healthy person, oftentimes college students looking for drug money, looking for beer money for the weekend. You give them a very small dose of the drug, and then you watch them very carefully. And then if it's okay in them, then you give the next group of patients just a little teeny bit more. And you escalate it up to the anticipated dose that's going to be going. And you just really, really pay attention to the safety. And so that's phase 1. So if it proves that there's no huge safety red flags with the drug, then it goes into phase 2, which is you start playing around with a limited number of doses, 2, maybe 3, maybe 4 doses, and you start going into the target population, means the type of people that you really want to treat. Okay, in this case, it's going to be somebody with HBV. And so you, again, primarily looking at safety. But in this case, you can also start to see, you start looking at hints that it might be working. So that's an initial efficacy evaluation. And these studies usually have dozens or maybe up to hundreds of people, depending upon the complexity of the design. Then if everything's cool in there, and phase 2 is indicated, okay, yeah, this is the best dose to use. It's safe at that dose. It appears to be working in people at that dose. Then you'll go to phase 3, which is oftentimes called a registration trial. Those are really big trials involving hundreds to many thousands of people. Some vaccine trials can involve tens of thousands of people. And here you're testing the final dosing in the target population. And you're looking for both safety and, importantly, efficacy. This is where you really, really make the absolute statement that, hey, this drug works this well in this many patients. And so those are phase 3 trials. If everything goes really, really well there, then you can apply for licensure to sell the drug. If you get the licensure, then it starts being given to people. And that's referred to as real world dosing, because how people take drugs in real life is oftentimes a little bit different than it's done in a clinical trial. It's easier to forget when you take your drug, things like that. And so there's also a lot more people that are receiving the drug. And so rare side effects can sometimes crop up. So the companies are required to monitor for side effects and efficacy for multiple years after approval of a drug. And this can really get into hundreds of thousands of people at a time. So that's the process of clinical testing. And if it's done right, at the bottom end of it, you end up with a drug that's helping a lot of people. Okay, so where are we currently with drugs against HBV? We got the approved drugs, nucleoside analogs and interferon alpha. Those have been mentioned a couple of times. There's many, many new drug mechanisms that have been validated in the lab. Clinical testing of monotherapies, that means one drug at a time. The drug has to be shown to be safe and have their intended effect before being tested in combinations. Why put things together if you don't know if they work properly in the first place? And so those, in many cases, there are many types of drugs that have gone through those and have been shown to be safe and effective by themselves, but of course they're not curative. And the goal is to cure people, so you need the combinations. And so we've got 16 direct-acting antivirals, 14 immune-activating drugs, and 3 monoclonal antibodies that are listed on the HBF drug watch pages for HBV. And that's my go-to place to always check to see what's the status of drug development against HBV. It's an absolute goldmine of information, so I encourage you to go there. And so then the combination trials are ongoing. There's a lot of them ongoing right now. And they're just entering their second, third iterations. And the really exciting part is functional cure rates of up to around 40% have been reported in some small early trials. Whether those will hold when we get to larger trials and more complex patient populations, you never can tell. But at this point, the leading types of therapies are showing some pretty good promise to provide a major improvement over a current generation of therapies. So I'm pretty excited about that. And so this, I believe, is my last slide. It's just hurdles to expanding treatment indications for HBV therapies. This is a difficult disease to design drugs for and get past the FDA. It's got a very slow disease course. It takes decades to reach traditional clinical endpoints. And for HBV, those are cirrhosis and liver cancer. And nobody wants to run a clinical trial that long. The patients certainly don't want to be in a clinical trial for 22 years. So it's difficult to impossible to design a clinical trial to assess these endpoints perfectly, the way that scientists would really like to see. So you have to make some compromises in your design. And then you have a safe, fairly effective nucleoside analog drugs out there. And that's important because new drugs must be what's referred to as non-inferior to preceding ones. And non-inferiority means they're not worse. Okay, they can be just the same, but hopefully better. But they can't be worse. And if we've got some drugs that are actually pretty good already, that means that the barrier to getting a new drug approved is just that much higher. Okay, and they have to be, and that of course also applies not only to efficacy or how well they work, but also to safety. And the existing drugs are really safe, and so that presents again another bar to trying to design combinational therapies. And finally, there's the conservative medical guidelines. You need convincing positive results to change treatment guidelines. And that stems from the basic philosophy of modern medicine as encapsulated in the Hippocratic Oath that's taken by all physicians. One of the parts of the oath is do no harm. And so they don't want to take risks with patients' lives and health. And of course, that makes a lot of sense. But that also means that ideas cannot be easily acted upon in human beings, even if basic science says that change would help. And I also want to stress that conservatism is appropriate because you have to be careful when you're doing an experiment with a human being. All right, I do believe that is my last slide. Oh, summary and final thoughts. Here's my thoughts. HBV and HDV are very different. Curing HBV will cure HDV. Functional goal is functional cure is the goal. You guys can read this. I mean, yeah. So I hope I've advanced your understanding here a little bit. I'm happy to take any questions if I still have any time.
Thank you so much, Dr. Tavis. I think we're gonna move to Dr. Block and then do combined questions for you both. in after Dr. Block's presentation, if that's okay on your
Oh,
side.
that makes perfect sense.
All right, awesome. And okay, there you are, Dr. Block. So I'm
Thank
gonna
you.
give you the spotlight, and then
Thank
Anusha
you.
is gonna share the screen. So welcome, Dr.
You
Block.
know, ideally, if I could advance the slides myself, but I will. Would that create too much trouble if I go to share my slides? Or
We can,
I mean,
yeah, you can do
do this.
that.
I don't want to take up too much time, but
No, go ahead, Dr. Block, if you
I'm
have
gonna
your slides
try.
up and ready. Yeah,
All
sure.
right. Someone
And
else is. All right, so I can try now.
yeah, and I can
Oh,
introduce
very
you as
well.
well,
Thank you.
if you'd like. Um,
So
yeah,
is my slide, is the screen showing my slides?
it is. It's just not in presentation view.
All right. Let's not get all in a tizzy. Uh,
So you just,
oh
yeah,
my
click that and it
God.
should be good. Yep,
It's
there you
enormous on
are.
my screen. All right. Well,
Perfect.
thank you. Thank you very much, Dr. Freeland and the speakers from Sherry to John to Sue. Very helpful to start. I'm Tim Block. As was said, I'm the co-founder of the Hepatitis B Foundation and its research enterprises. And I was a professor for decades at Jefferson Medical School, Drexel Medical School, Penn, and most recently Yale as a visiting professor. So I've been working in the area of hepatitis B for, well, almost since it was discovered, one of the last remaining standing. But so I'm going to give you a little bit of a different perspective on things, which I guess is, I hope it's useful. I'm going to talk about the rise and fall, and then the rise again, I hope, of HPV treatments. And I really mean it because it's been a roller coaster ride. So there's going to be a little bit of history in this. I'm going to skip over a couple of slides because they were covered, but you'll see them as they zoom by. And then I hope I'm going to end up with telling you I want to be hopeful. That's my nature. But I also want to be honest about where we stand and what the challenges are. So, no, I don't have a timer on. Okay, it's 2:28. All right, so this slide, you saw pretty much iterations of this. But what I want you to see here is this is the globe. This is the total human population, 8 billion people. This is what the World Health Organization estimates is the number of people who've been infected with hepatitis B. That's 2 billion people. So that's a very, very common infection. We used to have a tagline at the foundation, someone you know has been affected by hepatitis B. That is true. There isn't anybody who doesn't know someone or isn't affected themselves by hepatitis B. Now, of these 2 billion people, it's true, only a measly 257 million are chronically infected, as that's the virus is in them and can't come out. And those are the people who are at greatest risk for liver disease over decades, as Dr. Wang pointed out and Tavis did, and the people who need treatment. But you know, this is what I was trying to get at in the chat. Of these 2 billion people, if they go on to the wrong kind of drug, certain kinds of chemotherapies for arthritis or digestive diseases or cancer chemotherapy, they can reactivate quite a bit and join the need population. So we're talking about a very big problem. You are not alone if you've got chronic hepatitis B. So you'd think there'd be a lot of interest in seeing something done. I'm going to skip over this slide because you saw this ubiquity slide before. And so you think there'd be a stampede to treatment and help people with chronic hepatitis B since so many people are affected and it causes so much disease. And if you just look at this kind of step down ladder or waterfall, they call it, numbers of people with the disease down to people who are treated. So in the green, 257 million, that's, these numbers are wild estimates, but even if they're wrong by 20, 30%, they're huge numbers. Of those, less than about 10% have been diagnosed, know they have the disease. So, 36 million out of almost 300 million. And of those, only 7 million people are receiving treatment. So only a couple percent of everyone who has the disease is actually even being treated. And that should be a surprise to us. Well, that should really, I don't know, inspire people or motivate people to do something. I mean, I have this running against the HIV numbers. Look at this. And this is admirable. I'm not disparaging HIV, but 38 million people in the world, maybe 40 million with it. 32 million people know they have it. So that's 80%, 82%. And and once you know you have HIV, you get treated. Once you know you have HBV, there's still only about a 15 to 20% chance you'll get treated. So you can see where my I don't know, passion lies. All right. If you look at the, this is what I was talking about, about the trajectory of the arc of hepatitis B history from the drug discovery perspective. It was discovered well, first published in 67, discovered in 65 by Baruch Blumberg and Disnich and Harvey Alter, I want to point out. Now, Dr. Blumberg, with whom I worked, received the Nobel Prize in 77 for his discovery of hepatitis B. I just want to point out that working with him on this was Harvey Alter, who was his younger associate, wasn't his fellow yet, was his associate, and he helped discover hepatitis B. He then went on, he didn't get the Nobel Prize for that and was never bitter about it, and it just happens. He went on to discover hepatitis C with Michael Houghton and also credited as Charlie Rice. And they won the Nobel Prize in 2020 for the discovery. This Nobel Prize accounting business is something that we follow, obviously, in academics. But I just point out the remarkable kind of pedigrees and quality of scientists involved in working on Hep B. Then you got someone like Alter and Blumberg and so on. I can include Tavis in that too. We have some very fine people on both sides. No, we have some. I can't hear the laughter. I'm sorry. You can put it in the chat box. Very fine people all over hepatitis B. Well, there was discovered in the early 60s, mid 60s. And then we went a long time before there were any medicines for hepatitis B. The interferons were first approved for use in actually they were approved a little after that. They were first introduced in 91 for treating Hep B. And later on it was a pegylated form. But and then you see what looks like a pretty busy time of drug through for the next 20 years over here. Well, that's not really true. I mean, these are all the same drug. No, they're not all the same drug. And oh my gosh, if the people who discovered them are on, they'd be offended. They're all very different, but they all hit the same target. They pretty much all hit the same target, the viral polymerase. And so we weren't really getting mechanistically new drugs. We were just getting more and betters of the same drugs. And there's still only about, all in today, only 6 different drugs for hepatitis B, or 7 and 8, depending on how you want to count them. Compare that to, I just looked this up before I got on ChatGPT. How many diabetes drugs are there? Dr. Wang, tell me, because she talks about this. There are over 72 different drugs approved for use for diabetes, none of the different types of diabetes, more than 35, 45 for HIV. We have basically 2 drugs for hepatitis B, the polymerase inhibitors and the interferons. So although this seems like a large steady rise, it's really not, and these are effective drugs. I don't want to knock them, and Dr. Tavis talked about this, and Wang, I mean, they're very effective for what they do, but we keep on hitting the same nail with the same hammer. And we know that that's probably not the right way to go. So hepatitis, let me show you here. So we were kind of holding here in the 2010, 2015 area, and hepatitis C was cured, was pretty much cured. Hepatitis C, that created this wave of excitement of drug trials for hepatitis B, and I'm showing you here all these little blue dots. I'm going to go into this in a moment in another table to talk about what the drugs are, but you can see each little pill here shows you there was a lot going on in 2016, and it was pretty exciting. I'm showing you here the different phases. You heard about in preclinical from Dr. Tavis. The clinical phase is phase 3 and then approved here. And a lot was going on in 2016, very crowded. The immune modulators, not so many. Host acting, not so many, but a lot of DAAs, direct acting antivirals. So, okay, that was pretty exciting. That was the last decade. And then, whoa, drugs fail. And one after one, you can't read these lines, and that's intentional. No, they're small. I just printed them out from a paper. But one after the other, drug trial, failure. Oh, no, they're not even failures. I'm arguing with myself. They're disappointments. They weren't even failures necessarily. They were disappointments. The drug didn't achieve a sufficient endpoint to convince the sponsor, that is the company, that there would be enough market and demand. So program after program stopped. And if you look over here, I list them a little more clearly in a table, and one after the other, after the other, after the other. And I don't even have them all here. I got to update them until now we get to the point where look at the thinning of the herd where we are today. And so that's why I said the rise and fall. We had a little bit of fall. I think that's concerning. As sponsors worry, they get frustrated. And I want to tell you something, for those of you who care about hepatitis B treatment. Hepatitis B Foundation has been there from the beginning. When we started, and don't get me started, read my book. When we met with regulators and legislators and people from public health, there was no interest in Hep B. Then there was a little bit, you saw the latter, a little bit of interest in Hep B, then none, then a lot in 2016. Now we're in a lull again. Hepatitis B Foundation keeps its finger on the pulse, and that's what I think you heard Dr. Cohen say at the beginning. I want to emphasize that. That's the importance of the Hepatitis B Foundation. We've been there since 1991. We're here in 2024. So we're there. So we have to worry about this. Now, if you look at the table, it's not so bad. There still is actually quite a lot of activity. And so these are the clinical phases. My label came off. 15 drugs in phase 1, 21 in phase 2, and 2 and 1.5, let's say, in phase 3. And this is, I think, where we stand now. I took this from the Hep B Foundation Drug Watch, which is pretty much the definitive go-to place. The companies do it. CDC goes to our website to check them out. And this is maintained by a very capable person. No, my wife, Joan, does it. So she keeps her eyes open for drugs when they come, and people tend to report them to her. And if you can look at at what's out there now, look at this. There's this growth of immunotherapeutics out there, which if Dr. Tavis talked about this is kind of the area, one way or another, people think if you're going to cure Hep B, direct-acting antivirals are very important. And the drug he's working on is a very clever drug, and we need them. And we just submitted a paper talking about how important it is to develop those direct-acting antivirals. They're going to be very important, new ones. But pretty much most people believe if you want to cure hepatitis B, you're going to need to do something about the immune system. So looking at this proliferation here in the phase 1 and preclinical, I don't have it here, but I have it in another slide, drugs, very exciting. Therapeutic vaccine. What does that mean? You shoot up someone with the hepatitis B virus gene products and try to get their immune system to recognize the virus, which it couldn't do before. And you need some tricks to do that. You can't just give someone a vaccine. And that's the subject of another talk. But there are some innate host activators, these toll receptors, as they're called. There are monoclonal antibodies. And down here, very importantly, are checkpoint inhibitors and some agonists. And I want to point that out because that's kind of a cancer drug knockoff, which could be very effective. And they follow through here in phase 2. Very important that they make it to phase 2, and of course ultimately phase 3. But look at the what I'll call the casualty rate of drugs in development. What's the likelihood that a drug here in phase 1 will make it to phase 2? 63%. What's the likelihood that a drug in phase 2 will make it to approval? 21%. That's just 1/5. Now, if you started here in preclinical, likelihood of a drug going from phase 1 all the way to approval, less than 10%. So that if you remember that kind of cone, that filter that Dr. Tavis had up, this is it in a kind of a linear fashion to actually put some percentages on it that I took from, I don't know, I have the source on it here. I'm blocking it because my computer. Oh, where is this from? This thing called Biomed Tracker. But I think this is about right. If you make it to phase 3, you have a pretty good chance of getting approved. And we have 2 drugs in some stage of phase 3. I'm not really counting Hepcludex because that should be approved. I mean, that should be a done deal, but there's some mess up. But the GSK antisense or whatever it is, this is the one that I find personally most exciting at the moment, and we're really looking forward to it. So only one of 2 of the drugs right here are going to make it all the way to approval. So of this whole list here, say goodbye to most of these. It's painful because some of them are from our groups. Only 4 of these guys are going to make it, and only 1 of these guys. Well, actually, that's not true. See, we're going to have 2 of these approved. All right. Well, what's the goal of therapy? You heard a lot of that from Dr. Tavis and Wang, and I'm going to cover it just a little bit differently here. I think the goal should be an absolute cure. My definition of a cure, which I tried to voice onto the foundation, but I don't think we took it, and no publication, no society takes it. My definition of a cure is returning returning someone who has chronic hepatitis B to what I'll say is an age-adjusted risk of liver disease. It's, in other words, as if you never had hepatitis B. If you're a 40-year-old man and you have chronic hepatitis B, you're cured. That to me means you have the same lifestyle, same risk as someone who never had hepatitis B. Most people consider that to be ridiculous and unachievable. That, in my mind, should always be the goal, though. Now, I don't think that's possible right now. And people who are even functionally cured must continue to be screened for liver cancer. And I won't even get into it, but I am aware of us seeing people becoming aware of people cured of their viral hepatitis, not getting screened for putatively cured of the viral hepatitis. I don't know if Dr. Wang wants to speak to this. Not being seen, not going back for cancer surveillance, and in 15 years getting a cancer. So I'm very sensitive to the fact that this goal here, it does not exist yet. So it doesn't happen. So don't, as far as I know. All right. Well, we don't know in whom it exists. So we have to settle, as Dr. Tavis said, for what is definitionally called a functional cure. So what does that mean? So here's the liver with someone with hepatitis B. You've got integrated DNA, you got cccDNA, pre-genome, the virions, subgenomic RNA, all the viral proteins, and they're all coming out into the circulation. That's what I'm showing here. So what does a functional cure mean? It means you get rid of everything in the circulation, pretty much, including most of the HBsAg, including most of the, and of course, all the virions. So you go from this crowded bloodstream to this, and that by definition, absent cellular enzymes like ALT, that is our definition of functional cure. You can go off your drugs and maintain this basically virus relatively free, antigen anemia free condition. And your risk of liver disease, it is reasoned, and there's now growing evidence for this. This is happening in real time, right? It takes decades to know whether someone is really going to get sick from the hepatitis B. Once you achieve this goal, you have you've come a long way clinically. I mean, I don't want to put the numbers on it because it's kind of creepy. The reduction of risk from liver disease is between 50 and 80%, maybe even more. It's actually still not enough in my opinion, but that's a big drop. And in most populations, you can kind of find out who the people are who are going to be at greatest risk. Those are the people who got treated the latest, still had a lot of cirrhosis when they started treatment, or have some certainly viral genotypes. But for the most part, if you get to this, you're not home free, but that is virus control. Pretty good shape. Now, progress. Right now, we know that even with the lowly drugs, tenofovir, nukes, and interferons, 3 to 5% are curable. We'll actually reach that functional cure and probably something a little bit beyond that. And so we're there. But I want to talk to what we now know about who can be cured, functionally cured, with the drugs that are out there right now. Because I think that it's important, and we make this argument to the drug company people and the regulators, the money people, the legislators, that hepatitis B, there has been progress, and it's something that people with hepatitis B should know about. This complicated slide here, it's deliberately complicated because I wanted you to see I took it right from a paper. It's an old paper. I have the newer version of it now, but take a look at this. HBsAg loss, so that's the viral protein that people use as a marker of hepatitis B in your blood. That disappears. If that disappears in your blood, the reasoning is can't be any virus in your blood, and you're on and that's a very favorable sign. Right now, if you get treated with interferon for an extended period of time, 3 to 7% of the people who are e antigen positive will reach that goal. And these are for the various treatments. You can just see all along. There are people who are treated with these drugs who reach this goal. I mean, it's pretty pathetic if you're just on a nuke, but if you're on if you're on a nuke and with interferon, I'm going to get to these clinical categories of people who really are curable now. You could almost use precision medicine and say, because you have these properties, I think you can be functionally cured. And down here now, the HBe antigen negatives obviously perform a little worse. But look at this study that came out, that was reported by Herod just recently, and it was updated in the 2024 meetings, ASLD meetings, and they have some, I can't manage this. You can see right here that in terms of HBsAg loss, right now under some treatment regimens, overall you can achieve about a 13% goal with the right treatment regimens for a long enough period of time. And if you break this down into baseline, that is at the beginning of treatment, how much hepatitis B surface antigen is in this individual's bloodstream. If you have less than 1,000 international units, whatever that is, less than 1,000 international units per milliliter of HBsAg in your blood, and you're Caucasian, you have a 41% chance of being essentially cured, functionally cured, we'll call it, of hepatitis B. That's a dramatic thing to say. Now, you have to qualify. You got to be Caucasian. You got to have this level. And if you have a greater number, it's still about 5%. And I think Dr. Wang was getting into this in her talk. If you're Asian and non-Caucasian, basically, the numbers are far less satisfying. But still, if you have less than 100 international units, you can be cured too. Now, unfortunately, these overall numbers represent only a small number, as you see here, of the total population who have HBsAg. So is this glass, 15% full, or are we, 85% empty? Well, obviously, there's much more work to be done because most people aren't in this category. But I would say, if you look here right now, you can achieve very profound HBsAg losses in the right populations, and that is a big step forward. And you want to make sure, if possible, your caregiver, your doctor, and you know what is your HBsAg level and what your DNA level is. And that's modern medicine now. And I know many people on listening might not be able to do that, and then should revert to the World Health Organization guidelines. But if you can find these things out, then you can benefit from what I'm taking the credit, what Marion Peters called at a talk she gave to us, precision medicine for hepatitis B. Okay. Now, there are new approaches. Let me just see here. I've been talking for, I can't remember, 20 minutes. I'm sorry, I lost track of my time. There are new approaches to reach functional cure. Dr. Tavis touched on them, and I'll just summarize them here by category. There are siRNAs, and antisenses. These are nucleic acids that a patient can be given. These are in phase 2 and phase 3 clinical trials that whack down the virus for sure. They're having a very powerful effect, and they're almost certainly going to be one of these or two of these approved for use over the next 3 or 4 years, in my opinion, and they'll be a very important part of what I will consider a new backbone of therapy. Okay, this is a plug for me. We have hepatotargeting HBsAg reducers. We do, and they went to phase 1. Had some problems. Forgive me for being a little self-promotional, but these are from our center. They're and we'll see how far they go. They're CRISPR-Cas, these gene editing products. They've got a long way to go, but they certainly are precision medicines for knocking down cccDNA. And then, of course, these very important immuno-enhancing elements. And we're just going to have to be smarter about how they're used to capture that 85% of the people who are not in low HBsAg antigen conditions. And I think Dr. Tavis talked about this. We're going to have to combine basically a direct-acting antiviral that suppresses viremia and antigenemia with some kind of immunostimulator. And that will also go onto the backbone, I believe, of existing therapy. This is from Bob Gish, and it's just showing these things I talked about, replication inhibitors, new antigen reducers, immune stimulators, they're out there. Those are the drugs. You see they got the little numbers here? They exist. They're in clinical trials today. We just have to get these guys to kind of work together because I think that as monotherapies, which is why I think there's been some clinical disappointments, as monotherapies are simple add-ons to the current standard of care, which is the nukes. I don't think these new guys will do enough. We're probably going to need for the hard to treat hepatitis B patients, probably 3 drugs, I hate to say, at least. I hope that's not true, but at least for proof of principle, for the short term, I think there'll be 3 different mechanism drugs that will be needed. And the companies, we have to try to get them to work together on that. There are some very exciting drugs in preclinical development. Preclinical means, on my slide anyway, not in people yet. So where do I have, I hope I have, oh, good. I was going to say, I hope I have Dr. Tavis's drug on here. Yeah, good. So because there's some very, very exciting drugs that are just in laboratory and experimental systems, preclinical meaning animals. And I think the answer may be in here. So we gotta hold together here. You see some of the CRISPR-Cas drugs here, the gene editing drugs here, some of the new therapeutic vaccines, which are really exciting and doing great things in animal studies. So we got to hold on for those. But here's what we got, in my opinion, is the most promising. And right now, the next one we're all watching is Bepi, as we call it, because no one can pronounce, or I can't pronounce it. And this is a kind of an antisense, a nucleics, and it's having very, very exciting results that in my opinion are suggesting a whole confidence pathway of dealing with chronic hepatitis B. The Algos compound, the capsid inhibitors, exceeded my expectation, frankly, and it's resulting in, of course, direct-acting antiviral suppression, but also at S antigen induction. I wish I could put something up here like the Replicor compound. I don't know where that is anymore. That had been one of my favorites for a while. There are things out there. We just have to remain confident. And this is the step up ladder of treatment with hepatitis B. Now this, you don't know this, but this was actually the ladder that I took from a Mike Sophia slide. And Mike Sophia is one of the discoverers of the cure for hepatitis C. By the way, an adjunct member of the Blumberg faculty, and his labs were at the Pennsylvania Biotech Center. And I say I took it from him because this was for Hep C. So Hep C, getting to 100% cure for Hep C, which he and Mingau and some other great scientists got us to, it didn't happen. We didn't go from 5% cure to 100% cure with one drug. It took 15 years, actually less time than HBV, I admit, but 15 years, and a little bump for interferon, a little bump for ribavirin and interferon, a little bump for pegatron, and then a little bump for the protease inhibitors, until finally you got the big lift from their drugs. Well, that's where we are with Hep B. We're around here right now with precision medicine. We're in the 13 to 20% I can cure you rate. We need some of those other drugs that came from my table. And that's going to happen from investment in research, the drug companies, but quite frankly, not to be too self-promotional, far be it for me to toot my own horn, or our horn, it's going to be from the Hepatitis B Foundation. I mean, we're the ones who keep the advocacy every year. And no matter how every year someone tells us, oh, you should go advocate for this, and you ought to add this, and you ought to add that, and you ought to, and not that the other diseases aren't important, and they are so important. And if you have them, they're the most important. And, you know, believe me, at 69, I have like a large number of them now. So I'm all for it. But for hepatitis B, it's the Hepatitis B Foundation. For For hepatitis D, it's the Hepatitis B Foundation. And frankly, for better or worse, for liver cancer, and largely liver cirrhosis, it's the Hepatitis B Foundation. We're the ones who stick with it. So with that, I think I ended on time. Thank you
Yeah.
very much for listening. And I don't know what I do. I keep my face up or, oh, I have to
Yes,
stop
please.
sharing. Okay, sorry.
Yeah, if
All right.
you can, perfect. So we're just going to ask a few questions, Dr. Block and Dr. Tavis, to you guys. We had some come in. I think some were answered, but I think some are worth repeating because I think it's important to kind of maybe dive a little bit deeper into some of these concepts because we hear these questions all the time from people with hepatitis B around the world. One of the questions we got, is there a difference between exposed and infected with hepatitis B? And could one of you maybe clarify that? I know Dr. Tavis, you answered in the chat, maybe if you wanted to start with that one.
Yeah, the difference in that is relative to whether or not you've established a chronic infection. In that context, the term is somebody had HBV get into them, but it didn't establish a chronic infection. So exposed means that, in most cases means that they cleared an acute infection, whereas otherwise it means a chronic infection.
Thank you. Great response there. Another question that came in the chat, is it true that currently a very small, and Dr. Blocken, you kind of covered this a little bit, is it true that currently a very small group of people clear the virus? Can you share what that percentage is? And is there something that makes someone more likely to clear it?
Yes, very briefly. I mean, in the natural history of chronic hepatitis B, if you're infected at a very young age, let's say before the age of 2 or 3, and certainly at birth, the likelihood is you'll be a chronic carrier, as I call them, we shouldn't call it that, with hepatitis B for the remainder of your life. Now, some people do, if you're infected or exposed as an adult, let's say above the age of 15 or 20, the overwhelming likelihood is that you will clear the virus, have an acute infection, probably won't even know you were infected, and then the virus leaves you. Although some people have a very serious hepatitis. And then there's the in-between. If you're a chronic carrier, around 0.5% or 1% of the diminished every year, clear the virus just spontaneously. And it is not known why. It isn't known why. And it varies with the continent you're on. It varies with probably the genotype you're in. And I don't think that's really known why. I don't know if, John, you want to add to that? It's
No,
not
really.
Some
I
people
mean,
clear it.
in
There are
general,
theories, but
yeah, the less virus you have, the easier it is to cure. Obviously, the big one is age of infection. Yeah, I don't think we know enough about it to give a definitive answer.
But why do some people lose it spontaneously? It does happen. That happens a lot for young people.
Yeah.
Their
We know
livers
that
are
less.
growing, they're exposed to other things. They're just theories to throw at it. And older people, it could be maybe another infection with something causes some kind of sympathetic cross immunity. That's one idea. Something stimulates the innate host defenses, perhaps. It isn't known, in my opinion.
Great, thank you. A lot more to be learned, I think, from that. Another question that we got in the chat, does everyone need medication for hepatitis B? Why or why not?
I see Dr. Wang's on and John may think. So, this is controversial. Obviously, not everybody with hepatitis B needs treatment because only if you're untreated over their lifetime, only 15 to 25% of the people with chronic hepatitis B get seriously sick. If we knew who that 15 or 25% were, those who are the people who should be treated. But it's not known. So you play this game of estimates and you fall into risk categories. And you saw, I think, both with Dr. Tavis and Wang, you saw that those charts that showed who has active hepatitis, active replication over the lifetime of a person who might have chronic hepatitis B and who doesn't. And with drugs such as the nukes, which prevent replication, it only makes sense to treat people with active replication. And layer on top of that, it only makes sense to treat people with active replication and some evidence of, let's say, active hepatitis. That's the debate. In my opinion, if you had a good, safe drug, and I'm going to make this argument, and maybe John wants to say something. If you had a good, safe drug, one that you knew was safe, and you knew you had chronic, and you knew you had hepatitis B in you replicating, if I were, I can even get emotional about this. I know so many people, and it's personal, young people who did not get treated, that virus in them, but of course their livers, they didn't have liver enzymes in their blood, so they didn't have hepatitis that could be measured non-invasively. They didn't have hepatitis, they didn't get treated, and now here they are, 30, 40 years old, entering a more active hepatitis range with a virus integrating into their DNA every day. With, as you heard Sue talk about, the way you reach the age of 40 or 50, you have practically no T cells in you against hepatitis B. So now you won't even be able to benefit from the immunotherapeutics. I would have wished they could have been treated with even a replication inhibitor. And I'll add one more thing. There's a cohort of patients being studied, not studied, but being followed, who were treated. I'll even, some of them were treated by Kathy Schwartz, a pediatrician. Some were treated, I can't remember, by Phil Rosenthal. Anyway, they're people who were treated when they were young, and very young with hepatitis B, some with interferon, some with the nukes. And a large number of them now, as adults, have cleared the virus. That I haven't seen that published. That's I guess I'm just speaking from anecdotes. People I've known who've been treated as children at a much greater number. Now, again, I'm getting way off facts here because I'm speaking from just my own anecdotes. So should everybody be treated? The professional guidelines say no. They define who should be treated, and you saw those tables. Those are people with virus levels above a certain amount. It's like the NASDAQ, it's up and it's down every year, or or interest rates. But people with virus levels above a certain amount should be treated, and with ALT levels above a certain amount, that's who should be treated according to the guidelines. I've told you differently. I don't know if John wants to say.
I completely agree. The Hepatitis B Foundation has released a statement requesting broadening of the treatment guidelines. I'm one of the signatories on that. And ICE HBV, that's the International Coalition to Eliminate HBV. It's a association of many of the leading HBV scientists in the world, is also acting very forcefully to try and broaden the treatment guidelines. We just reviewed all of the data and the basic and clinical data relating to that, and the conclusion, at least in my mind, is black and white, that the treatment guidelines should be very significantly expanded. And so we have a pair of papers under review right now, one addressing the patient public health aspects and one addressing the scientific and medical aspects that I hope we hear good news on soon, because the pair of papers together make a powerful argument for expanding treatment guidelines.
Great, thank you. Well, given time, I think that we will have to wrap up questions, but I think there will be probably time to, if you don't mind, check out the chat box, because we have had some comments come through there. At this time, I'd like to transition over to our storyteller panel and introduce and welcome our storytellers, Joe, Bright, and Wendy. If you guys could turn on your cameras now. Anusha is going to be sharing the screen. Next slide, please, Anusha. So one aspect at the Hepatitis B Foundation that we're probably most proud of is our engagement and development of the Hepatitis B Foundation Just Be Storytelling program, which was launched in 2017, and it brought together individuals with lived experience to come together and share their stories and create videos, which you'll see played shortly. We're going to start with Joe's story, and you'll hear the impact and see it, hopefully. And the goal of this program is really to raise awareness and create a voice for those with lived experience. So Anusha, I'll have you go ahead and play Joe's story, and then we'll invite Joe to give some opening remarks and reflections from that.
I was always smelling the flowers, digging in the garden. In the mid-70s, as a young gay flower child, I faced my fears and came out to myself, my mom, and friends. One day a friend said, "Hey Joe, your skin's a little yellow. You should see a doctor." I found out I have hepatitis B, but was told nothing about what that meant, and I just forgot about it. The AIDS crisis hit. Everybody was worried. I got tested and was relieved. I'm negative, but I did still have hepatitis B. I learned how to be safe. I did lots of research at hospital libraries. I faced my fears again, and I came out to my gay men's community about having hepatitis. I still didn't feel ill when, in 2013, my liver became inflamed. It turned out I'm also infected with a rare, serious virus, hepatitis delta. In a follow-up email, the specialist typed, "There's no good treatment. Good luck." I wasn't about to leave it up to luck. I got online and found out about hepatitis delta and that it only affects people who also have hepatitis B. I wish they had had the Hep B vaccine back in the 70s. It could have prevented both viruses. So, the only drug trial for hepatitis delta in the US was at the National Institutes of Health. I hoped this trial could save my life. I joined, flew across the country some 60 times in 6 years to get the treatments I needed. Last December, the Delta virus in my body was near zero. The treatment was really working. Then, with just 2 months of the trial left, I fell ill, really ill. I lost 25 pounds in 3 weeks, and my abdomen filled with fluid. In drug trials, the patient's well-being is always the first priority. My doctors took me off the drugs, and I've recovered. Sure, I'm disappointed I didn't finish the trial, but I feel so good about my part in the research. I'm still being tested, still monitoring myself, and I'm still hopeful we'll find a cure. Just be persistent.
Great. Thank you so much. And welcome, Joe. If you wanted to maybe share some reflections of your story and provide an update on what's happened since you created this video.
Yeah. Thank you. It's good to be here. I'm during in 20 minutes ago there was a very loud earthquake and tsunami alert on my phone, and we are safe. It happened up near Eureka, California, 7.0 earthquake, which we did not feel. But I'm a little, um, uh, shaken up mentally anyway. Um, but I wanted to share two things I found out uh, just at the beginning of our conference about myself personally. Um, uh, University of San Francisco, who has been caring for me since my liver transplant in April 2023. Just this morning, I was told that my tacrolimus, one of my anti-rejection drugs, is being reduced yet again. I'm down to 3 milligrams a day, which is really, really good news. And then I had my monthly blood tests. I'm monitored monthly, and once again, my hepatitis B surface antigen is negative. It's been negative since my transplant, and that's always good news. Yeah, and so after I made that video in 2019, which was I didn't know what a great thing making that video would be because I connected with the Hepatitis B Foundation and I had no idea how much of a positive influence meeting you all would be. I had people, first Sierra and then other people at the Hep B Foundation gently nagging me, I'll say it that way, to see about getting on a liver transplant list. And I wasn't that worried, even though the clinical trial didn't work out for me. Initially, my hepatitis delta numbers were low. They slowly went up after that clinical trial, but they were never horribly high. And so I wasn't that worried. But people at the B Foundation, including um, Sierra and later Dr. Gish, said, Joe, you really have to push to get on a transplant list. And my the MELD is the method of of determining your liver health. My MELD was low, um, and it slowly went up. So you can't get on a liver transplant list unless your MELD reaches a certain point. And in a populous state like California, your MELD has to be quite high. Um, so in March of 2023, my MELD got higher, and I didn't really have serious symptoms from Hep B and Hep Delta until about 2022. And then around the same time I got COVID. Right after that, I started having problems like ascites, fluid in my abdomen and in my legs, which got worse and worse. And then I had varices, bleeding in the esophagus, which can be very serious. And my albumin level was going down and down and down. And eventually I had to get albumin infusions once a week. And then finally, it was another crisis unrelated to my liver disease that got me in the hospital. But that crisis, it all combined, I think, to make my liver score go up just 1 point high enough to be sent to UCSF in April of 2023. And then I wasn't meant to go there, and the approval process is normally several weeks of intense testing and interviews with doctors, neurologists, hepatologists, social workers. You have to prove that you will have good care when you're home recovering from a transplant. You're tested for everything from opium to alcohol. Um, you know, anyway, that testing, all of that approval process took 4 days because they were in a hurry. And I was in a hurry. And on day 5, they said, Joe, we've got a liver for you. And they prepped me and took me to surgery, and then my doctor Roberts came out and said, you know, Joe, sorry, this liver is no good. I was not crushed. I was not horribly upset because I knew, I kept telling myself it's not my liver until it's in my body and working. So I still felt, well, they're really trying for me. And I felt like there was hope for me. Anyway, a half an hour later, after they said no to the new liver, they came back and they said, there's another liver. Just a half an hour later on day 5 after being at UCSF. And in the morning, I woke up with a new liver, jumped to today, and my monthly blood test results are really good. My creatinine went way up, and I asked UCSF this morning about that, and they said, well, we're reducing your tacrolimus, and that should help with your creatinine. So other than that, I'm doing great. And that's my story.
Awesome. Thank you, Joe. Thanks for being here, especially given the emergency situation going on around you. I'm glad you're okay. But thank you again for sharing your amazing story. And we're happy that we've been a part of it and seen you along your journey. I think it's been an incredible story to watch. And we're just so happy and proud of like your health and where you are now. Thank you. So we'll move on to our next story. And I hope, Joe, that you'll check out the chat. There's been a lot of people saying hello and saying how awesome your story is and how amazing you are as well.
Great.
So
Thank you.
yeah, and we have questions coming up in just a little bit. So now we're going to turn to Bright, who many of you may know as our podcast co-host. But I'll hand it over and we'll share Bright's story, and then we'll give him an opportunity to share updates and reflections.
I was born in a small town in Ghana. My family was not wealthy or powerful, but my mom cared for me and my 4 brothers. We loved her special pancakes made with nutmeg and fried in coconut oil. Somehow, I managed to finish teacher training college, won the American visa lottery, and emigrated to the US. I was shy and quiet, but I thought of myself as pretty strong and resilient. Life had not been easy. 5 years later, I learned that my mom had passed away back home. All of my earlier strength and resilience fell away. I couldn't concentrate. I wanted to hide from the world, and sometimes I didn't want to live anymore. My friends helped me so much. They said, "You loved your mom. She would not be happy seeing you give up on your life." So I got some counseling and I got a little stronger again. But then I started feeling tired all the time. 4 or 5 days a week, I had absolutely no energy. My doctor helped me, and eventually I learned that I was living with chronic hepatitis B. I started treatment, but the fatigue and back pain got worse. Were they connected? Every morning, I woke worrying about my future and what will happen next with my hepatitis. I might be okay today, but what about tomorrow? Or next year? Or 5 years from now? Slowly, I started to have days when I wasn't hopeless, when I could face the unknown. I talked to my doctors, did my own research, and made my own decisions. A year later, My brother came from Ghana, and I picked him up from the bus station. After a moment, he said, "You have changed." I couldn't imagine what he saw so quickly in me. But now I realize I have changed. I am more resilient than ever before. Just be resilient.
Great. Over to you, Bright.
Uh, Once again, I want to thank the Hepatitis B Foundation for the opportunity. And when I did this video, it feels like I haven't seen this video actually in a few years now. And so watching it brings back all the memories. My initial decision to do this video was I wanted to help prevent other children from becoming statistics as I became, learning that I have acquired this virus from childbirth. So that was my initial decision. And then once I did a video, I didn't have any idea. I thought going in, I just do the video and Hepatitis B Foundation will just take the video, and that's the end of my journey there. Little did I know that my journey will actually, that was the beginning of a journey I didn't plan or I didn't even vision was going to happen. After the video, yes, I still have the health issues still. I still deal with the health issues, but the connections, the opportunities to the Hepatitis B Foundation that have, those doors that have been opened to me through advocacy and stuff. I mean, I look back sometimes and I look at some of the stuff I've done in the Hepatitis B space. I ask myself, how did I get to do all those things? Because it wasn't something that I planned or I even dreamt about, but all through the hard work of Hepatitis B Foundation and the opportunity they always give patients to share their experience, those have opened doors for me. And I'm grateful for the connections, for the relationships, for the friendships that I've been able to build throughout all this. And also because of this, actually, I have also found a career path that I didn't think I would be on. But through all this, I think I found the right path and something that I'm passionate about. And so I feel very grateful and very thankful. I'm still resilient, still stubborn as usual, and I still have the don't give up attitude where I'm very optimistic. I always look at everything as a half glass full. Even when my limbs are off, I always think, hey, you know what? I still have another limb, and so life moves on. And so that has been what has kept me going. And I really thank the foundation. I can't thank the foundation enough because I wouldn't have the opportunities I've had. I mean, I can't imagine. I never dreamt of being at Capitol Hill advocating for hepatitis B. I never dreamt of that, but I've been on Capitol Hill a few times advocating for hepatitis B, and it's marveling and surprising, but it's all thanks to the Hep B Foundation and all they do for Hep B patients and allowing us to share our story. So that's a little update on where I am. Thank you.
Thanks, Bright. And thank you for your commitment because, you know, you had a choice to get involved and to not be as much involved. And you've definitely been so involved in so many different things and really looking forward to seeing what you'll accomplish in the future. It's been a pleasure working with you and seeing your story evolve as well. I hope also you'll check out the chat because a lot of people are giving you shout outs as well. It's great to see. Thank you, Bright. We'll get to some questions to you in just a minute. Now we'll move on to Wendy's story. Wendy, let's go ahead and share your story and I'll put the spotlight on you.
My parents were immigrants from China, and I was born in Canada. I lived a pretty typical North American upbringing, celebrating Christmas, going on car trips. I was also athletic when I was younger, excelled in sports. I thought I was invincible. It wasn't until university that I found out I have hepatitis B. All I knew was that I got it from my mom at birth and that it could be transmitted to others. My soon-to-be husband was tested too. We were relieved to find out he was not infected. At that time, I didn't think I had to change my lifestyle. Then about 15 years later, in the fall, my family found out my mom had liver cancer. We were devastated. She had never been treated for hepatitis B, nor had an abdominal ultrasound. That Christmas, while the family sat together in the living room, my mom held my 3-year-old daughter on her lap and sang a Chinese song to her, hoping she would remember it. She knew she would never get to see her grandchildren grow up. She died a few months later. It was a wake-up call for me. I realized, wow, this is serious. I learned about a quarter of the people who have the virus eventually develop liver cancer. We need to be monitored and educate ourselves. Some doctors don't always know as much about hepatitis B as those of us who have it. So it is important to find a doctor who is knowledgeable about the treatment of this condition. Now I monitor myself more regularly, get abdominal ultrasounds, live healthier. I want to be there for my family, for the grandkids I hope to have one day. Just be hopeful.
All right, Wendy, over to you for some reflections and updates.
Okay, can you hear me?
Yes.
Okay, great. So I did that Storyteller video in 2018, and really so much has changed since then. At that time, I wasn't on any medication and was still in the immune tolerant phase of the disease. So I had a very high viral load and fairly stable liver enzymes. I'm also E antigen positive. My fiber scan showed I did not have fibrosis in my liver. However, in 2020, at the age of 58, my liver enzymes, especially my ALT, start to rise. I had entered the immune active phase, so my hepatologist prescribed entecavir for me. And as many of you with HBV know, it was a relief to finally put on antivirals since I feared developing liver cirrhosis and cancer like my mom. Unfortunately, soon after taking entecavir, I developed a severe skin rash throughout my body. It looked like my back had been whipped by a belt. It was so painful. And of course, I thought it was an allergic reaction to the medication. My specialist switched me to tenofovir, or Remedy, to see if my rash improved. It did not. So I asked him if I could reduce my dosage. He reluctantly agreed to. It did help, but my rash persisted, and I was diagnosed with chronic idiopathic urticaria, meaning I had this rash for over 6 months, and no one knew what was causing it. The allergy specialist, though, speculated that as my viral load decreased, my immune system had less virus to attack, so it went after my skin. But of course, no one knows what the cause was. Eventually, though, I was prescribed an effective antihistamine that helped me to control my rash. So I started taking tenofovir every day as prescribed. So while on medication, my viral load decreased from many millions to under 100, but never went undetectable, which was disappointing to me. Then last year, it started to increase to many hundreds, which was concerning to me and my doctors. My hepatologist decided to run resistance tests on my virus and found that it had a mutation that was resistant to tenofovir. I don't know, perhaps it was a result of taking the medication, not taking the medication consistently in the beginning, or because I was treated at an older age, which allowed my virus to mutate. No one knows the answer. The good news, though, is that upon further testing, it was found my virus was not resistant to lamivudine, which has been mentioned as one of the older antivirals, and it has a high resistance profile, so it's not considered a first-line medication. Nevertheless, and because of these test results, my doctor started me on lamivudine in December of 2023, and I've continued to take tenofovir. Since then, my viral load has gone down, and I've had 2 readings under 25 and 1 at 25. While this is kind of a victory for now, I know my virus can develop a resistance to lamivudine. So every time I have my blood tested, I'm filled with anxiety as I wait for my results and wonder if my viral load will start to go up again. I don't know what my options will be if that is the case. It's awful, which is why I want to share my story at this conference. And finally, as Dr. Sue mentioned, other cancers are more prevalent in people living with HBV. A couple of years ago, a nodule was found in my pancreas, which was found to be a lipoma. However, it's another issue to think about every time I have an abdominal ultrasound. Further, my immune system has been compromised for years, probably due to having chronic HBV. I've always had a low white blood count and neutrophils, and hasn't gone up. So, as I can tell from my story and other people's stories, living with this disease can be so challenging. And like all of us, I keep hoping and praying that a functional cure can one day be found. Thank you.
Thank you, Wendy. And thanks just for pointing out some of the other challenges that go along with hepatitis B and some of the anxieties that go along with it, because I think they're real for so many people that are directly impacted. So I appreciate you bringing attention to that, because I think it's often kind of not really highlighted, but so important to discuss. I want to turn to our storytellers now to just ask them a few questions about maybe starting out with what sort of tips or advice might you have for others with hepatitis B or Delta, and maybe particularly for somebody who's just been diagnosed? I see Joe, you're off mute if you wanted to start us off, and then we'll go to Bright and then Wendy.
Excuse me. Oh, advice. Well, in my case, one of my doctors in 2013, who actually was mentioned today, and I'm not going to mention that person's name now, but I was told there is really nothing for my hepatitis delta at all, and basically told good luck. And so my advice, what I did, which maybe if you're new to a diagnosis with B and or hepatitis delta, is to do your own research. Of course, what I didn't know about back then was the Hep B Foundation. So it's all there. But along with that, what I did was I looked for clinical trials, because at the time I said, I don't want to wait for something to come along. I mean, I might be dead before something comes along. And to me, it was worth looking for a trial and seeing, you know, seeing what it entailed and what the risks were. And I went ahead and did that. The other thing that I did when I first learned I might have cirrhosis back in around the year 2003 was I took to heart what the hepatologist told me. That was Dr. Bass way back when at UCSF, which is to take care of yourself. Um, I had never been a heavy drinker, but when I told him that I had, 2 or 3 glasses of wine a year and maybe a beer a week, he said, no, zero, not at all. And I thought to myself, I've had hundreds of gallons of alcohol in my adult life, and I've tried marijuana, blah, blah, blah. I don't need to do it anymore. That was my attitude. Um, and I stopped using supplements, um, other than vitamins maybe, but I was very careful about herbal supplements. But the basic advice is take care of yourself. Really, to me, those little pleasures which are often damaging, are just not worth it. To be alive and be out in the world, it's been so worthwhile to take care of myself and to exercise. And I think also, if you do wind up, getting a liver transplant, the more you take care of yourself beforehand, the better. And while you're waiting for new drugs, the more you take care of yourself, the better. The less you might need drugs that cause other problems.
Thank you so much, Joe. Couldn't agree more. Take care of yourself and do your own research, I think are super important messages for people. Bright, anything to add to that?
Yeah, sure. I think that for me personally, what I find helpful was the educational piece. I mean, it's like a lot of times. So when I got diagnosed, nobody gave me any information. It was just like, you have hepatitis B, that was it. There wasn't any information. Nobody told me what to expect and all that kind of nothing. So I have to put in the time. And that was after a while, because I just spent time kind of, I won't say mourning, but kind of more in a depressive state, processing the whole diagnosis and asking questions: why me? Why now? Why not someone else? It was a messy place. But then I got to a point where I realized, okay, let me rather use that time to learn more about the hepatitis B virus. And I can testify that that was helpful. It did take a lot of the mental toll I was putting my body through and the psychological struggle. That was helpful, because I came to understand what hepatitis B is and what it does and what it doesn't do. And so it kind of took some of the fears and the worries away. So education is an important thing that I think we all can benefit from. Also, when we get a diagnosis, one thing we all do is we forget to live. We forget to do the things we love. We forget completely. We ignore everything we have been doing and just focus on that diagnosis. And so all that becomes of us is HPV, but it doesn't have to be that way. We still have to live. Remember, always try to find time to smile, find time to breathe, find time to do the things you are passionate about. The diagnosis should not put you in a coffin or put you in a box that you kind of block yourself or lock yourself out of everything else. No, you still have to remember to live your life. And besides, always remember you are not alone. There are millions of us out there, so you are not alone.
Amazing. Thank you, Bright. Really great advice. Appreciate that. Wendy.
Yeah, I totally agree with what Joe said about advocating for yourself. What I have found is that a lot of general practitioners don't really actually know the latest about HPV, because they have so many different conditions to address and to look at. So HPV is probably a very small portion of their practice. And so I was told that when I had a high viral load, my physician said, oh, maybe you should take the vaccine again. And obviously that wouldn't have helped at all. So it's just important to do your own research as to how HPV can affect you. And what you mainly need to do is make sure you get monitored, get your blood tested, get an ultrasound. Those are the things that my mom never had done until she was diagnosed with the incurable liver cancer. So it's scary to do that. I think all of us, like I said, every time I go get a blood test or an ultrasound, I'm filled with quite a bit of anxiety. But it's better to know and to be able to do something about it than to try to ignore it or sweep it under the rug, because it's not going to go away. If your viral load is increasing, or if your liver enzymes are increasing, or if they find something on your ultrasound, it's better to know about so it can be addressed. And I love what Bright said about enjoy your day. I know sometimes when I have a bad result, I'm like, you know what? I have today. I'm going to just try to enjoy it and get out there, get out. I love bike riding, so I'll just go up for a bike ride and I'm saying, hey, I can bike ride today. I can do something that I love doing. So I think that that is great advice. Don't let HPV define you. Sure, it's a big part of your life, but there's so much else in your life. You have your family or friends and your mobility or whatever. There are other things that you can celebrate and really appreciate more than just having HPV.
Thanks, Wendy. And also get connected to others. I think that also helps. And you can always reach out to the Hep B Foundation or the Hep B Community Support Group. I see Bright put that in the chat as well. It's a great resource to get connected. Wendy, I'd like to kind of pick up on something that you mentioned, both as you were reflecting on your story and in your response to the previous question. I think some people struggle with managing that liver health surveillance that happens. I think for some people, it's a cost challenge. For some people, it's access. For some, it's just that regular reminder. Can you give some advice to people about how you kind of motivate yourself to continue maintaining that?
Wow. I think one of the difference I have between probably, obviously from living in the States, I live in Canada. So we have access to ultrasounds and FibroScan. We don't have to pay for it. Our health insurance covers it. But I know there are other people here from Africa and the Far East. So I'm not sure what their situation is there for payment. That I could see being a limitation to be getting screened. As far as, but as I said earlier, it's just so important to just get out there and do it, even if it's just a liver, even if it's just a blood test, which I don't think is as expensive as an ultrasound or a FibroScan. It's scary, like I said too. But if you don't do it, it'd be scary if down the consequences where it's gone too far for you to be able to do anything about it. And it's something that I just really encourage people to go out there and try your best with the resources that are available to you.
Thanks so much, Wendy. Bright, anything to add on to that?
Yeah, I mean, it's hard. It's hard sometimes. I mean, I think sometimes the challenge, it all depends on the circumstance and the environment you are in. So I, for one, being in the West, I have access, just like Wendy said, I have access. So it's a little challenging my situation compared to someone else. But what I would say is just try and do the best you can do with what you have access to. I know it's not, and it's something I'm always furious and angry about when it comes to the inequality, whether it's access or treatment or other stuff when it comes to HPV. I'm always concerned about, because as I sit here and I talk loudly and proudly, I have access to everything, but I have family members in Ghana with HPV who do not have those kind of access. And so it's a piece that keeps me awake at night, that I worry as well. You know, I worry about them and their future and what will happen if anybody, God forbid, needs treatment. How is that going to, what is going to happen to them? You know, so it's tough. And I always think we can do better, and we always will strive to do better. And so don't I would say don't, yeah, it's difficult, but just find a way to manage, take it one day at a time, and it's tough. If you can find something that you are very passionate about, I find sometimes it's like, I find it interesting. With some people, when they get more busy, it actually doesn't help them. But I find getting busy and occupied help my mind. It takes my mind off whatever challenge I'm facing, because my concentration shifts to what I'm working on, rather than focusing on the Hep B stuff and all the testing and what the results could be. Yeah, behind my back, underneath is there, but my focus is somewhere else. And I think it also helps me a little bit because I have other health issues that I go through. So I don't get that much fear and the anxiety because of the already existing health issues I have with other health issues that I have to do testing for. So kind of I'm I don't know. I mean, it sounds like it laid the path for me to handle the Hep B a little bit better because I don't see much difference between Hep B. Yes, Hep B is a virus. Yes, it can kill, but it's similar. It's a chronic health disease as having high blood pressure. And you have to manage it. You have to monitor it. You have to put in the work. And so once I kind of draw that similarity, it helps me not look at one as being worse than the other, but I always look at them as like, oh, they are all kind of similar. And if I have to take off my blood pressure so I don't get heart attack or stroke, it's the same thing I have to do with Hep B so I don't destroy my liver. So I kind of relate each other in the same way. So that's all I would say.
Thanks, Bright. I appreciate the reminder that it's something that doesn't define you. It's a health condition, and keeping it in that mindset as something to manage, I think, is really important. Joe, over to you.
Yeah, just to kind of repeat and back up what both Bright and Wendy have to say. There's a lot in the world that worries me, especially now. I don't have to go into all of that. Probably most of you are worried about a lot of things. And I believe that we have to be truthful. There's a phrase in English or Pollyanna. Pollyanna was a little girl who just saw everything as wonderful, and it's like, don't be a Pollyanna. Um, the trick is to keep on top of your illness and but it's a trick to keep on top of it without it consuming your mental health and your spiritual health. But it is important because if you're depressed, I don't know if there's proof of this, but it seems that when you're depressed, you are sicker. And when you're depressed, you are less likely to take actions to take care of yourself and to be on top of your medical treatment. And that also ties in with, Wendy was talking about how, um, we meet people in the medical field who really don't know anything about hepatitis B, and even more so with hepatitis delta. And I'm often educating people when I go for care. I get infusions now, hepatitis B immunoglobulin. Now it's every 2 months, but I go in and I talk to the nurses. I tell them my story, and most of them have never heard of hepatitis delta. They don't even know what my immunoglobulin infusion is. There's no one else at my hospital who's ever gotten it. And so it's an opportunity. Uh, I not only, and I'm not the perfect representative because I'm not medically trained and I struggle to remember all the technical terms. Um, but then the other thing I do, and this is something people might consider who are new to this whole thing. I mean, it felt very good and very therapeutic. I felt like I was doing something useful by being a hepatitis B storyteller. And so I don't know if that program is ongoing. There are maybe hundreds of stories now, but if that's an opportunity, or maybe you can create your own story to share in your community. But that I tell people to go to hepb.org, Joe's story, or Bright's story, or Wendy's story, uh, because it's all right there, and those stories get people to pay attention, and it's part of our process of educating our own healthcare providers.
Thanks, Joe. And last question really quickly to our storytellers. Last words of advice or wisdom might you have for the audience members? Joe, you're off mute, so I'll start with you.
I think I've said everything that I have to say at the moment.
Thanks, Joe.
You know, just take heart and realize that there are people working for you all over the world, and look to the Hep B Foundation as your first stop when you're trying to understand all of this.
Great. Thanks, Joe. And Bright?
Yeah, sure. So the final thing I would say is don't feel, I would say to many patients around the world is don't feel like you are alone in this battle, because you are not. There are millions of us, and I always believe that if we are all together, we are stronger. And so I hope you can find some comfort in knowing that you are not the only one fighting this battle, and knowing that there are a lot of people out there. And also don't forget, as I said, to live, remember to live, because it seems like we always forget about that, and we focus so much on hepatitis B and we leave everything else. So remember to live as well as you go through this battle, and be your own advocate whenever you can.
Great. Thanks, Bright. Great advice. Wendy?
I think one thing I would add is that if you haven't been familiar with everything like that has been discussed today, and yes, there was a lot of new information, but it can be very overwhelming. And I think that's where, like everyone has mentioned, go to support. Go to Hep B Foundation or the hepb.communityorg.org. I'm involved in both of them, and I've just found a wealth of information from that. But just if you find it too much, just take it in little chunks. Don't just flood yourself, because you might, get very overwhelmed and get depressed by all that information that is out there. So I myself have found that I've had to step back at times from looking at information. Even some of the presentations today, I just was like, oh man, that triggers, that hits a point because, drugs have dropped off and all these disappointments have happened with the drug development. But then at the end, there was this promise of a phase 3 drug, and I'd heard about it. So I was glad that it was addressed, and I'm really hopeful that it will be approved eventually and that it will have success. But what I'm just saying is take it a little bits at a time if it's too much to take it all at once, because there was a lot of information that was presented today, and I heard it's going to be recorded. So if you feel good about it, just go back and look at it at a slower pace so that you can absorb it rather than just being flooded with it. And that's all I have to share.
Thank you so much, Wendy. And thanks again to Wendy, Bright, and Joe for sharing your stories. Your bravery and stories helps others not feel isolated and helps us continue to grow the hepatitis B family and the advocates that work to move the elimination agenda forward. And we greatly appreciate you all and are inspired by your voices. And I hope that you also saw that from others throughout the chat today, as there was much encouragement and appreciation there as well. So thank you all. One comment I think Joe made was suggesting, if you're interested in getting involved and if you've been inspired by Wendy, Bright, and Joe, you can be a storyteller too. You can apply by filling out the form on the slide here using the QR code here. And anyone who's been impacted by hepatitis B is more than welcome to apply. And it is quote unquote an application, but it's not super strenuous. It's just so we can get some contact information from you and understand your story a little bit. If you have any questions, you're welcome to email the email that I put in the chat a number of times. And we hope that you'll get involved and be part of this important program. With that, I'd like to turn it to the next slide and pass it over to Dr. Cohen, who will be providing closing remarks.
Thank you very much. My face hurts because I've been smiling so much, maybe crying a tiny bit too. This has been a really wonderful experience. I want to thank all of our speakers today. And I just wanted to share for just a few minutes some of my biggest takeaways. And I learned how to do this from Tim, Dr. Block. Thank you so much, because you've done this, and it inspired me to do it today. So I want to start with Dr. Su Wang. You said a few things that really stuck with me. Thank you for sharing with us the mechanisms and the life cycle of the virus, using Dr. Thomas Tu's tree analogy, which I think is really cool. And thank you for helping us understand how we use this information to identify targets for drug therapy. You know, you mentioned that all of our voices are needed. However anyone is comfortable with sharing their voice, we need those voices. And I think Tim confirmed that every single person has a critical role to play in ensuring a future with functional cure. Moving on to Dr. Tavis, thank you for helping us understand, you know, what a functional cure is scientifically and clinically, and what it can mean for people living with hepatitis B, and that functional cure is one of our major goals for future research. And I think we all felt the excitement in the research pipeline that you shared, but understand that we have to kind of balance optimism and patience, and hope that we know that we will continue to work to get there. Dr. Block, I think the first message I take from you is that we need to improve access to use of the current drugs we have right now, right? Obviously, we need to do a better job with increasing access to antiviral treatment. That's for sure. And that in the past decades, we have seen many hepatitis B drugs entering the research pipeline, and we have also seen company and drugs leaving the space in the past few years. But we still have a robust hepatitis B therapeutics pipeline, a robust functional cure pipeline. We just have to better understand the challenges and be patient and understand our role in the community to help make sure that companies don't leave the field, and to help promote hepatitis B treatment research. And then Joe and Bright and Wendy, I mean, I took pages and pages of notes, but here's what I want to take away. I think that the biggest things, the most important things to me, understanding the true impact of hepatitis B on people's lives, and not only on their life, but on their families' lives, and multiple generations of families, having the strength and the resilience to choose to be part of the movement to eliminate hepatitis B, to choose to be an advocate, to choose to be an educator. Thank you for sharing that. As you showed us, every person is needed and every voice is needed. Now more than ever, I think we need to really work together as a strong global community, scientists, clinicians, people living with hepatitis B, public health practitioners, small nonprofits. We need to find a way together to work towards prioritizing hepatitis B, hepatitis D, and liver cancer. And then just to end with a few thoughts, every story is unique. You know, we think we understand what it means to live with hepatitis B and hepatitis delta, but then we hear from more people. And I want to stress that we understand that every story is unique, every person is unique, and we cannot stop talking to people with hepatitis B and delta and bringing them to the table to be meaningful partners towards elimination of hepatitis B. And then, Bright, I'm going to shamelessly steal your words for some ending thoughts. Don't forget to smile, to breathe, and to live. You are not alone. Thank you.
Thank you so much, Dr. Cohen. And that concludes our webinar. Again, thank you so much to all of the amazing speakers for spending your afternoon with us on this important conference. We had a ton of engagement and wonderful feedback. So really appreciate all of you taking the time today to be with us. And thanks to our audience for being so engaged and being involved in these conversations as well. We really appreciate you being here, and hope that we'll hear from you in the coming days following the webinar. As you exit the webinar today, you will receive a survey. Please do fill that out and give us feedback. What do you want to know more about? What can we do to help improve the care that you may be getting related to hepatitis B? We want to hear from you, and that helps inform future programs that we do for you. So please do fill that out for us. And don't hesitate to get in touch and check out our website for more information on hepatitis B. Thank you again to GSK for sponsoring this webinar and for the translators as well for their amazing support in making sure this webinar is accessible in a number of different languages. Thank you all so much. And with that, we'll end our webinar. Thanks, everyone.